Right, we are live. Okay. So, hello and a very warm welcome to our brilliant speakers and everyone who's watching this live stream from all over the world. My name is Krisada and I'll be your MC for today. First and foremost, I'd like to thank everyone for allocating time in their busy schedules to attend Charisma Movement's first ever virtual health forum, No Holdbacks. I would also like to thank all of our event partners and participating organizations in making this event one for the books. If at any point you require assistance or would like to ask a question, our on-ground team is on standby. Today, we will be covering two sessions, namely community health and mental health. Now, all of you must be very excited, so wait no further as I present to you our first keynote speaker for the event, Dr. Lim Chi Han. Just a little short bio before we go along. Dr. Lim is a senior researcher at Third World Network and a founding member of Agora Society Malaysia. He holds a PhD in infection biology from Hanover Medical School, Germany, and a master's in science in immunology and a bachelor's in science in biotechnology from Imperial College London. Health and socioeconomic policies are his concerns. He's a columnist at the Malaysian Insight as well as Oriental Daily. He is also involved in public health and right advocacy campaigns in Together Against Cancer and Family Frontiers as a central committee member in both NGOs. If at any point you have any questions, please do put them in the Slido. The link is in the chat and Dr. Lim will tend to as many as possible. With that said, I would like to pass the floor to Dr. Lim. Dr. Lim, the floor is all yours.
Good afternoon. Thanks, Krisada, for the wonderful and passionate introduction of myself. I'm very delighted to be here. Thanks to the organizer, Charisma Movement, for having this event. I do think that this is a fantastic and brilliant event to have because most of the people, when they think about health, that's only when things goes wrong. They seek treatment. To them, the concept of health is healthcare. Yeah, so I think the title of this event is No Holdbacks Addressing Health Taboos in Malaysia. Why people not talking about health? Why there's no good health knowledge and awareness in the community? I think if you want to tackle this health taboos issue, I think first thing you have to know what is how the system is running in Malaysia. You know your rights. Yeah. I'm a health researcher and advocate and health activist on many issues. And I'm from today I'm representing my coalition called People's Health Forum. And I'd like to introduce a bit about my coalition. It's a platform created in 2019, April, by several not-for-profit organizations. You can see the logos below, and individuals are committed to the principle of healthcare as a human right. That means universal healthcare as an entitlement based on the ability, not on the ability to pay, but based on the basis of need. So we're talking about healthcare reforms. We're concerned about the health financing issues. We want to ensure there is affordable access to medicine. So the health equity on many fronts. So these are the issues that brought us together. So I'm very delighted to share with you about what we think about the health system in Malaysia. Yeah, so there's a difference between health and healthcare. A lot of people tend to mix these two together, but according to the WHO, the World Health Organization, definition in 1948, health is actually equivalent to the well-being. It is defined as the physical, mental, and social well-being, and not merely the absence of disease and infirmity. That's very important. So when we talk about the health, it covers a lot of things, including healthcare. Yeah. So what is outside the subset of healthcare is the preventive health, health promotion, and health, environmental health, and health R&D. So there are other factors that keep our society healthy, but they are not really treating the sick, because the best cure is prevention on the health issues. All right, and about the right to health, actually, it's not a very new thing. In the same year, the Universal Declaration of Human Rights, in the Article 25, it actually stated that everyone has the right to a standard of living adequate for the health and well-being of himself and of a family, including food, clothing, housing, medical care, and necessary social services. Yeah, and then the motherhood and childhood are entitled to special care and assistance. So all children, whether born in the or out of the wedlock, also should enjoy the same social protection. I think this is a very defining definition. They shape our health system later on after our independence. We took a lot of public health measure, taking care of the pregnant mothers and then the children when they are born. According to our constitution as well, although we don't have some kind of definition like the Universal Declaration of Human Rights on right to health, there's not something that's specified directly like right to health. But if you can go to the federal constitution and you find that health matter actually is listed in the 9th schedule, list 1, federal list, means our federal government actually is the main entity authority taking care of health matters. So what is defined in their job scope is that they have to run hospitals, clinics, dispensaries. They have to train medical and approve medical professions, the doctor license and so on, and then have to take care about maternity and child welfare. And those are the lepers, and leper institutions are those old infectious disease dated diseases. But they also have to take care of the poisons and dangerous drugs according to the definition set by the MOH. And so about the liquors, drugs, all this, have some kind of even cigarettes have to have some kind of regulation set by the MOH. But it doesn't mean that other level of governments are not involved in health. If you look down to the list 3 in the 9th schedule of our federal constitution, it's a called concurrent list, means it's a responsibility for all 3 levels of the government, state government and local governments. Since local governments elections have been abolished and then local governments are actually put under the state governments, so the state governments has a responsibility on the public health issue as well, more on the sanitation side to prevent diseases such as dengue and those pollution that caused by illegal run factories and commercial entities. So drainage, irrigation, all these are very important in keeping us healthy. So so it's not just our MOH is in charge, but your state government and local government as well on the health matters. And a lot of time, probably Malaysians would be disbelieved that there are people in the world out there thinking that Malaysia is the best, in terms of healthcare. There's one index listed Malaysia as number 1 in 2019 by this International Living magazine. But how true is that? And probably you have to look at what organization, what magazine is this? Probably they're talking about those expats, those wealthy residents that can afford to come to Malaysia and have a good life because they have the capital and they probably can seek for really the best of the healthcare in Malaysia. But the reality probably is very stark compared to contrast to us, the citizen in Malaysia, because we probably don't have the means. So we have to look thing to judge, to assess what is the state of healthcare or the health in Malaysia differently to those expats. So I would like to introduce you the 2 concepts. It will be described in shapes, one triangle and one box. The triangle is the iron triangle of healthcare. So a lot of times you want these 3 things: the access, and you want the cost to be low, affordable to yourself, and then you want good quality. But a lot of times, if the government has a limited budget constraint and also human resource constraint, there's only how much you can address it to these three main factors. Which one you want to improve on? If you want to improve of access to everyone, a lot of people, then you have to think about the cost. If you have deep pocket, also the cost can also run very high if you want super good quality, like those standard that those experts are looking for. Then it will cost a lot. A boom. Is it something the government can afford, or is there anything you probably want to think about compromise or regulate a bit so that you can get the best optimal outcome? That's the job of a government and then our civil society to ensure what is the fair outcome, what is health equity to us, means to us. And then another concept is, in the box. This is actually universal health coverage concept brought by the WHO in 2015. It actually tells you about the sort of coverage in a box concept. Yeah, you have three axes. One to the left at the lower bottom is talking about population, who to cover. If you want to cover a lot of people, then the next axis is about the services. Which services are covered in the public healthcare, for example? Because to many other countries, for example, oral, I mean the dental service, all these are not in the coverage. So you have to pay out of pocket yourself, like in Australia and some other places. These are not under the coverage. You have to buy different kind of health insurance. So you have to ask what services are covered also. Do they also include the vaccination? Yeah. And then lastly, the y-axis to the top means the financial protection. So how much do you expect the ordinary people to pay out of pocket? If you can provide to a lot of people and a wide variety of services, but this is not free, then this will also affect the access, the coverage. Then a lot of people, because they don't have enough money, then they probably have to skip some of the services on offer. So the best scenario is you fill the whole box. That is the best outcome, the coverage that government can dream of. But you have to think about the resources and whether you can have the means to cover that. Because when talking about services, there are some areas or specialties probably you need certain medical professions to handle. And also about the population, then it's about the accessibility. Whether you have a lot of health clinics or hospital in a great proximity to where people live and work. For sure that, probably some of you know about this SDG, means Sustainable Development Goals by United Nations. And the indicator number 3 is on good health and well-being. So for sustainable development, have to consider on the health aspect as long also on other economic and other social aspects as well. So health is to ensure healthy lives and promote well-being for all at all ages. So this is a pretty big ambition and aims for the WHO and the United Nations for us to fulfill this ambition and goals. So another thing is that who are the actors in this healthcare system? We focus narrow to healthcare only. So one thing is that you have to ask who is paying. So there will be a payer, then there will be people providing you service. So those are service providers. And all these have to be regulated because especially for the service provider, you want to ensure some kind of quality. And you don't want doctors, you don't want dangerously risky run medical institutions. So you need some kind of acts and laws to ensure things go according to the regulation and laws. So these three are in the main actors in the healthcare. But a lot of time Malaysians take it for granted because we have this public healthcare system that we only need to pay very nominal sum to get the treatment. So who are the payer? It's not possible that your 1 ringgit and 5 ringgit can do the wonder for all this treatment and medicines. So someone is paying. In the Malaysia system, it will be the government. And For the service provider, we often have to talk about the primary care, means the clinic kesehatan or medical clinics in your locality, and secondary and tertiary care usually means hospital-based services. Then if then when we talk about health, also there are certain things that we can probably a system. Then you have to talk about these topics, whether which area you want to improve on. So if you want to talk to the government or talk to the health authority, you have to understand that these are the building blocks for health. So one thing is about service delivery, another is about workforce, because you need people to provide the service, and then importantly also on the health information system, or your medical records, where is it kept and how is analyzed for the government to plan for the development and the next services. Access to essential medicines, this one cannot be overstated, is very important, because a lot of treatments are really reliant on medicines. Then very big thing is on financing, because all this will cost money, and how these things will be decided in the end, although this is put in the sixth block, but this is probably the most important one, is about leadership and governance, because they a lot of times how much budget for Ministry of Health and how many hospitals the government wants to build, it's all down to political decision as well. In the pool of the finance the government have collected, how they distribute this fund and allocate for health is very important. So what are the 4 outcomes that we are looking for? For sure, we want to have the improved health status. We want all members of society to become healthy, and we want the healthcare system to be responsive. When there is a problem, you don't take 6 or 2 months to solve, because, for example, the COVID-19 pandemic, it can hit you very soon, and probably you're late by 5 days for lockdown or some kind of response, you miss a big mark. Yeah, and then the third outcome, very important goal, is to ensure that health equity. I mean, the social and financial risk protection, because you cannot ask for all level of society to pay the same amount for different risks and different kind of disease that one face. No one likes to become sick. Yeah, it's not a fun thing. So when there's some misfortune fall onto you, it's not that of your choosing. It could be some kind of accident, something. So all members of society have to get reasonable protection. It's not based on the ability to pay, but it's based on rights. You actually enjoy this right to health. And lastly, we also want the health delivery system to be efficient. How they manage their resources, how even the space within the hospital. Now a lot of people complain about the crowdedness. They are very scary. They feel very scary because now, because of a pandemic, they want to keep some kind of a physical distance or all this. So there's a lot of planning to do. So these are the building blocks that you should consider when talking about health. And Malaysian healthcare system, if you look at this chart, it looks like a very complicated thing, but actually it's down to 4 actors. Federal government, like I say, the main responsibility falls on the Ministry of Health. And then the Ministry of Education also play a part in providing the healthcare. As you know, have UMC, UKM also have their own hospitals. These are the minor player. And then very big part also played by private private sector, because we have few thousands of private clinics and 200 something of private hospitals. They play a very important role. You see, for our public healthcare, those charges actually stuck at the value actually stuck at 30 years ago, more than 30 years ago. It has not been adjusted at all. So some say that they collect your $1. Actually, they actually cost more for them to actually administrate the registration than just $1, the charge. So So it's really free healthcare to all of us, all the citizens and residents in Malaysia. Even for if you look for specialist service, you would get the referral from the clinic. Then the first visit is free, and then the follow up is just 5 ringgit. It's ridiculous. It's nothing that you can compare to the private sector. Yeah, and then about the ward also, if you have serious problem, you have to be admitted in the hospital. Those charges are reasonable. If you don't have money, yeah, you can also use the second class or third class. Third class is $3. Even if you have nothing at all, then your hospital can consider a waiver for you. If you can prove that actually you just impoverish, you cannot afford anything, they will waive. Yeah. So why all this good thing happened to us? There's some historical reason. Our healthcare system is actually inspired by the National Health Service created in the UK in the 50s. And we follow the Beveridge models, means nationalized healthcare. It has 3 features. Means it's a universal single payer insurance, means all the payment actually provided by the government to pay for your treatment. It's financed by taxes collected from all the revenues the government generated. So they ask nothing from you because they assume that somehow you have paid the tax, whether direct or indirect. Indirect means SST, last time GST, all this lah. Then second thing is the public healthcare provision. So government actually owns all these hospital and clinics and run it themselves. Compared to other countries, this might not be the same. So we still have this very obviously under MOH and MOE. And free care. This is very important. Care provided for free at the point of care. So they don't ask you for money. They just ask you for identification. If you are a citizen, yes, you are entitled to these rights. Yeah, of course, we have some kind of exceptions. There are some things nowadays you have to buy addition to the treatment. So this would have some problems, especially for the cancer patient and heart disease patient. But there are actually NGOs helping to fill the gap on all this shortage. So our system, healthcare system, basically still follow this mantra from the Beveridge system. We should be bersyukur lah we have this system still running, because in the world, like I say, there are other type of healthcare model or finance system. For example, I talk about Bismarck. I used to study in Germany. I understand this very well. Every month you have, when you are employed, you have to pay the health insurance. It's quite costly, I'll tell you, very costly. And the country actually don't have public medical institution run by the government. It's all private run, and then they will get the sum, the payment from the insurance company. It can be a publicly run insurance company or private run company. So this system has a historic background, like Germany and some other follow this system. Then it's hard for them to change because all these models have some kind of why they come a long way along, and it's hard to just switch. And nowadays a lot of people in Malaysia talking about national health insurance because they think that the government has no money and probably there's a lot of restrictions. So why not ask those who can still able to afford to pay some money into a separate pool of money, then set up this national health insurance so that people also can access to the private health care. This actually has some important implication. But if you look at there are some countries running this system pretty well. Yeah, so you have to think about changing another system based on currently what we have already enjoyed, who actually already benefited, and who actually will be asked to make the payment. This actually will be very complicated. I think I need another lecture on this, but I'll tell you that what we have, the system currently is still running okay, and there are problems that we can solve later. I will describe. And lastly, what's the worst thing to have is to have no system at all. It's everything paid out of pocket. There are a lot of developing countries experiencing that because the federal government is not strong enough. They don't have the foundation laid on their healthcare system. So all private run system and everyone paid out of pocket. This is the worst case of scenario. But yeah, fortunately, Malaysia is not the case. Okay. And one thing is important that to note that why private hospital and private healthcare service could be expensive because it's using the fee for service model. Means whatever you whenever you go and seek healthcare, you have to pay based on the menu items, what treatment you need. So they will charge for every item, every services. And if you need more, you seriously need a very complicated procedure, then you have to pay more. So that is the models that actually can bring impoverishment in financial catastrophe for families that are not able to meet this kind of payment. So Malaysia public healthcare based on capitation means our MOH doctors are all pay money, abdominal, salary to take care of the services. So based on, so they are located in a one institution to take care of the population or the incoming patients for the particular day, for particular period. So there's capitation. So it's a fixed amount of payment. So based on number of enrollees means the citizens are around your area. Yeah, because if you are working and living in Klang, there's one public hospital you usually will go, you will not go very far. So this is the kind of system the public is running on capitation and private run on the fee for service. Yeah. And then, this is a state of play of in Malaysia. We have a lot more private clinics in the private, but our health clinics run by government actually is a much bigger clinics compared to the private clinics. A lot is just a one shop lot size, and probably have only one doctors. But for private clinic or for public clinics, clinic center usually have one or two more medical practitioners there. On outpatient visits, a lot more going for the public. And in terms of number of hospitals, private has more. This is a statistic about 4 or 5 years old, but I think the balance is still more or less there. Yeah, and even though private hospital has more, but in terms of number of beds, still our public healthcare sectors is leading. And number of bed days also. That means a lot of people, when they are admitted to the hospital, they would choose government hospitals for very good reason, because it's your right, and you will get taken care of at a very reasonable, affordable price. And doctors, we have a lot more in the public sector. You see the statistics already excluding housemen. Actually, housemen would take about a quarter, or those newly promoted medical officer, they will take a quarter of the health doctor workforce in hospital. So there's a lot more if you consider housemen and the fresh medical officers. So there's a lot more doctors in the public side. And then health expenditure side, we spend about half, slightly more to the public. Okay, and who pay for all this? Still a quarter of the finance actually come from the private household. OOP means out of pocket. You pay by yourself. This is the source of a lot of problems. If you have to go to the tertiary care at the private hospital, this can actually bankrupt you. If they have no option, and this is not you will find the finance protection, social protection at risk if you have to go for this model. But as you see, MOH carry about half of all the finance, and you see that SOCSO, all this will play a part, and health insurance companies actually contributed about 7.4% by 2020. Although there's a lot of effort of increasing private health insurance, still they are not the main determinant in terms of financing. All right, and what about budget for MOH? just recently announced in the Parliament, our budget 2022, health actually allocate the second highest after education. Most of the time, the second place is often either finance or MOF or MOH, but this year just slightly ahead for health. Then a lot of people also ask me whether it's enough or not. Then we have to look at what is actually allocated. Yeah, government spend about half for medical care, tertiary care, hospital-based care. Those are the expensive items, but it's a very urgent, important department because all the sick people have to be taken care of. Those are serious cases. If not, they can go to I think the private health. The orange pie has something missing there. There's the public health department. There's for the budget running the primary clinics, clinic kesehatan. This would take about 20% from there. So you look at the division, the primary care. I mean the public health department will actually run the disease control, health education, family health development. All this important division, and there's a lot more division in the medical care, about 30, about all the specialist department, and then the hospital management, and 10% actually used to purchase medicines. This is lumped into the specific programs. You see there is about 20%. Actually, it's about 10% there is only for medicines. So this is not cheap thing to consider because if you look at the operating budget, this consumes 28 billion for next year. Whether Malaysia spend enough or not, then you need to compare with the world. Yeah, what is the world average? Yeah, sorry about this axis. There are some countries not showing up, and the average is about 10.4, the world average, and Malaysia is here 8.5 only. That's how much we spend using the total government budget on health. If you look at other upper middle income countries such as South Africa and Thailand, they spend 13.3% for South Africa on health from the government expenditure, the total budget, and Thailand spent 15. It's about double of what we spend in Malaysia. So why this country, even though they are poorer than us, they are willing to spend more money on health compared to us? I don't think that because we spend less because we are healthier. I don't think that is the case lah. So that's actually questioning about the leadership and then the political will. And if you look at the graph has already adjusted. If you look at the bed occupancy rate in the major MOH state hospital, it's really running out. Actually the average is the threshold is about 70%. I mean all the state hospital have 70% bed occupancy at all time. That means if you anytime in 2019 you went into this hospital, you will find not many beds actually available. If you look at the hospital in Klang, Tengku Ampuan Rahimah, is even close to 90%. Actually, the turnover is very fast, and probably they don't have enough bed at times because this is just the average. Imagine there are times probably it's 100% or more than that. You have to have a sleep on the corridor. And this happened before the pandemic hit, this 2019. So this shows how prepared are we facing the pandemic when this really hit, and a lot of people have to be admitted to a hospital. You see those pictures of people just lying on the floor, on the bench, have no place to actually rest very well. This has the basis. So if you look at the status before the pandemic already very full, then we know that the government has to do something. So we need to talk about the demand and supply in terms of facilities and workforce. And it's actually for the past 10 years, from 2009 to 2019, the attendance for the public health facilities and admissions went up quite a lot. You see, it's only like 26% for admission and about 27% for outpatient attendance increase. But this translates to actually millions. Yeah, there's a lot of people actually coming to our public health facilities. But if you look at the facilities in terms of supply, if you look at the number of beds increased in the public hospital, it's just increased very little, very few, like 7% for public hospital and 30% of beds. How can this cope with the 26% increase in admission? Have anyone wondered about that? But if you look at the workforce, even though you see a lot more hospital doctors actually added to the workforce, but these are from the low base, because you can see that if we have millions of patients coming into our health facilities, and you only have increase of a few thousand, there's actually a lot more work to do. So these numbers don't tell the full picture, but this is a serious challenge for our public health system. So a lot of times also people got confusion about those roles of government. On the administrative side, you have Health Director General, which is currently Dr. Noor Hisham Abdullah, and Health Minister. They're actually not the two same role. Yeah. If you think about the company, Health Minister actually is the one who make the decision and make a political decision and a lot of leadership dealing with other the ministries, and then in the cabinet we fight for the rights. So all these are the role of the health minister, and health DG exists to keep the system afloat and manage the ministry, the health department. So it's like a CEO job compared to the chairman of the board of director. That is, the role is a health minister. So the political actor would be health minister, and due to the unfortunate circumstances back in 2020, when we have less able minister, then our health DG have to act up and play the role to stable the ship in the face of a pandemic. But this is a very unusual situation, because if you see from the pictures of a former health minister and the current prime minister, when they are really in charge, you see the health DG actually is behind them, not taking the lead. Yeah. And just have to. This is also your right, and also what they say that by the MOH is a client charter. These are the services, the minimum that you should expect from them. Yeah, for example, you would be called for the treatment in 30 minutes for the dental service, and 30 minutes is the standard for them. Once you register, then you will be able to see the first line of the health medical practitioners. So this is standard, their service standard. So this to address the waiting time issue. And so there are some kind of survey telling us about what is the state in the public and private healthcare. And if you look at those in the red bracket, those areas are the areas that public healthcare fare poorer. For example, waiting time to see doctor, ability to ask for more space and room, compared to the private. Waiting time is the worst lah. But if you look at the private side, what is worse for the private is the treatment charges, the second last bar at the bottom to the right. You can see 26% of the people, respondents, say that, it's very poor about the private healthcare treatment charges. So this is the issue about the healthcare. The long waiting time, a lot of people actually experience. I would just quickly, it says that you would take, even for university hospital, you would take 2 to 5 hours to actually get everything done. If it's about 5 hours, that means the half day, whole day, work day already gone. So there will be some kind of reduction in the productivity. And other complaints due to poor services, and sometimes doctors, because of stress, they make mistake as well. the government has to pay compensation for negligence or some other issues. So there are some problems with the public healthcare. Then lastly, I think I want to talk about the disease burden since we're talking about community health. These are the areas that as a society, Malaysian society have to improve because there are a lot of cases on the rising trends, especially on the NCD side. This is just a list. And what actually cause most premature death, also something related to health. Your health lifestyle, heart diseases, your lower respiratory infection, stroke, all this. There are a lot of NCD component in there. If you look at the National Health and Mobility Survey 2019, you'll see that 1 in 5 in Malaysia got diabetes. And you look at the line, it's on the rise from 2011 to 2019. Those have been diagnosed, and also including those did not know they have the disease, the blue line. You also see a sharp increase. It's good to see the sharp increase is in the sense that people actually are aware, know that they probably have the issue, then they go and seek treatment. That was not the case 10 years ago. A lot of people just pretend on it until some serious complication hit them. Yeah. There's a lot of people also have the three high, means high cholesterol, high sugar level, means diabetes, and high hypertension. If you look at the three circle in the Venn diagram, the subset in the middle means 8.1% of people, or equivalent to 1.7 million of people, currently with three major risk factors. These are serious problem. I think this could kill a lot more, if we don't care of our own healthcare. And 1 in 2 adults in Malaysia are overweight or obese, and 1 in 2 have abdominal opacity, and 1 in 4 not active physically, probably not even run, jog, walk for 20 minutes in a day in a medium or low intensity. They even feel that because I think a lot of people feel very convenient with the car and things like that. So all this have a cost. So my final words is that on health taboo, what to do about it is to know your rights, understand the system and issues. Then once you get that stage, then you can speak up and discuss with your community, because then because of your knowledge, then there are a lot more meaningful engagement. And if you have a lot of opinions and understanding about it, probably you can also spread your words by writing it or to the newspaper or on social media. Then on health equity, I think we need to start some movement, or at least you join some assisting movement to get all these like-minded people together. Then we can advocate for a cause. This is my last 2 slides. I'm also coordinator for this Manifesto Initiative. If you have interest about what health reform proposals people have been proposing, and all others policy areas such as education, environment, you're welcome to visit this Manifesto website to look for all these proposals. We want to see the betterment of the society. And with this, I thank you for your attention. I welcome some questions from you.
Okay, all right. That was really insightful. I think we have one question in Slido. The question is, what is a change that could be taken which would drastically improve Malaysian healthcare in general?
Quesada, please come again, because I heard the line is not stable. Let me see the question myself.
Yep.
What is the change that could be taken to drastically improve Malaysian health in general? On the public healthcare side, I guess the government has to invest sufficiently Last time when Pakatan Harapan came to power in their Pakatan Manifesto, actually they promised a 4% equivalent, 4% GDP equivalent of funding for the healthcare. And currently, governments are only paying 2% of the GDP for running the public healthcare. This is particularly low because given if you compare to other countries, um, in the world, they will spend about 6% of GDP on health. Malaysia just 4%, 2% from public and 2% from private. So there's a gap of 2%. And the previous government actually intended to close the gap, but they didn't show it in the budget that they put forward for 2 years while they were in power. Not also for the governments after that. So there's some kind of political view issue that they did not actually fulfill their promise and want to really prioritize health because even though pandemic threat and risk we are facing right now, they say a lot about strengthening public health and all this, but they never show in the numbers in the budget. This is something very worrying for me. What do I think the MOH can do better for the country? I think they have a lot of very capable professional and civil servant there. They did a lot of modeling or projection about the needs and what demand actually from the society. When they see the shift of the lifestyle patterns and then the NCD trends, they are actually very worrying and wanted to change the lifestyle as well. And they did to a certain extent. For example, under the Pakatan Harapan, they introduced the sweetened beverage tax. That is to cut the amount of sugar in those manufactured drinks. It's actually quite effective. Like I say, I actually observed because after the introduction of tax, the manufacturer they are willing to really reduce the level of sugar just because they don't want to pass the cost or to take up the cost of the tax in the form of tax. So I think that's something very effective. But there are a lot more nudges that the government can do. For example, impose the non-smoking area in the dining area. All this, yeah, something you can see very subtle, but actually a little bit helps. But there's when talking about major reform, we haven't seen that because there are a lot of pushback also from private sector, from certain lobbies. If you want to touch the liquor problem, you want to touch a cigarette vape problem, there will be people coming up to other ministry departments, show up there and say this for economy. You see, so for every political question, there's a health aspect and also there are some other aspect. So the government has to really think about what's actually the priority for the nation. You would think it's health, but to some other people would think it's economic development is more important. Then they'll cut your health, your forests because of economic development. Then this would actually have some implication to our health. Yeah, because we have lost our green lung and things like that. So when we talk about health, it's a very comprehensive thing. We have to think about the environment that we live in as well. Now we see more questions. Yeah. In regards for the healthcare workers, how can young people help in advocating for their rights? Yeah, healthcare workers issue. I think the government has to disentangle the civil service department, the public service department in the name of JPA, because they want to downsize the civil servant numbers. This are understood because if they add more civil servant, that means you have to increase the payroll, and then every year you have to have some kind of adjustment, and then you have to pay for their pension later on. So it's a big cost. But if in order for them to keep the cost low, they cannot just treat every civil servant the same. For example, we know that doctors, nurses, all these are also civil servants if they work in a public hospital. But you cannot treat this as the same level as those sitting in the aircon office in the Putrajaya administrative office. It's not the same civil servant. So I guess the contract medical the contract doctors issue is that these people are not put into permanent position soon enough. Then they got the treatment of discrimination and the uncertainty of their future. This actually is a systemic issue. actually can be dealt with if they can be more responsive to the problems, talk based on evidence and needs. They reprioritize and adjust the system. It can be done, but there's some departments just don't cross talk with each other, and yeah, so that's the issue. Have been going for decades, 1 decade or two.
I think there's one question about the disabled community which says what is the equality change in healthcare that can be reinforced by the MOH to empower them in terms of their needs. I think that's a very interesting question.
Yes, a very interesting question. Yeah, I think disabled community needs a lot more than just healthcare. Yeah, I think for their mobility, for the convenience of doing things, or even seeing the screen right now, there's a lot of awareness have to be raised. I think the public health department in the MOH is the best suited department because they have this program on health promotion to raise awareness about the for the disabled community, especially targeting on the local government side. Because if you talk about mobility and the urban design, this is something serious issue for the disabled community. If they have to go out, they will face a lot of obstacles and unwelcoming design that actually become their obstacles. So the local government have to be sensitive and responsive to all this also. So I guess health promotion unit probably have to work harder and to talk to all these stakeholders to improve the well-being of the disabled community.
Yep, I think we can go for one last question. As much as we encourage our public to seek help, are the healthcare workers responding well to it?
I think on the yeah because it's health is your own health. If you have if you find any problems, you should take responsibility for yourself because health I mean the healthcare workers cannot force anything. They ask you to come to see them or no give you any treatment if you don't want to seek for any treatment. So I think the communication has to be both ways because a lot of times also people in the community are not really fully aware about the risks or the problems that they are having. So if we have if you go to the Manifesto Rakyat website, I think I personally also put forward policy reform uh, calling for the government to set up some kind of family doctor system like in the UK, so that actually you have your own family doctors that can every year you have to go back to. And of course, this will bring benefit to the doctors because by capitation system, they also get extra money for seeing you. But to build the relationship between the patient and the doctor so that they know about yourself in the long term so they can provide continual care and stop anything bad from happening. Yeah, from happening because they see you every year. They can give you medical and health advice, and that will actually save a lot of troubles and cost from you if you just neglect on your own condition or you are not aware. So I think on the primary healthcare side, the government can do a lot better. This is one what People's Health Forum strongly advocate to strengthen our primary healthcare. So all the health problems have to be taken care and deal with at the primary level, not at the hospital. So this will make a lot of sense.
Yeah, yeah. I definitely agree with what you said. I think that was really, really insightful. Yeah, so thank you so much, Dr. Lim. That was really, really great, with the keynote speech and answering everybody's questions. Um, However, due to time constraints, I'm afraid that we will have to move on to the next segment of our forum, the session on community health. In this session, we'll be discussing inequalities in Malaysia's healthcare system and why equal access to quality healthcare is vital to the development of our society. So, yeah, thank you very much, Dr. Lim, once again for that wonderful keynote speech
Thank
and
you.
answering for this question.
Thank you for the invitation.
Yeah,
Nice having you. Yeah. Thank you.
thank you. Yeah, so for this segment, we have an amazing panel of speakers lined up. They are Miss Sarah from Doctors on Ground, and Dr. Ishriyanti, who is a family medicine specialist. So without further ado, I would like to pass the floor to this session's moderator, Amir, to get the discussion going. Amir, the floor is all yours.
Hello. Hi, thank you, Chris, for passing. Amazing speech by Dr. Lim previously. So, first and foremost, I would like to welcome Dr. Sarah and Dr. Isriyanti. Thank you for agreeing to attending our session today. And we would like to learn more about community health from you. So, welcome to the first session of the Health Symposium with the pressing topic of community health. So, together with me, we have Dr. Sarah, representative from Doctors on Ground Malaysia. She is the founding member of Doctors on the Ground, in fact. And Dr. Isriyanti, she is a family medicine specialist and is currently a senior lecturer in Perdana University, RCSI in Kuala Lumpur. So we will be diving on into the topic of community health, in particular healthcare inequality, the root cause of it, the symptoms of it, and what are the challenges faced by people in the field. So before we begin, just a bit of introduction. My name is Amir Adam, and I am currently the treasurer of Charisma Movement. I majored in economics, so nothing to do with healthcare. So it is really a pleasure to be learning a lot more on healthcare from you guys. So a couple of house rules. Audience can enter the questions in the box, and towards the end of the session, we will be choosing a few questions. You can either direct the questions to a specific speaker or keep it general for the speakers to answer and have a conversation between each other. So we would like to get straight to the topic at hand today and sit back and enjoy. But first and foremost, I think I didn't do justice in introducing you guys. So I would like for the speakers to just perhaps briefly introduce yourselves and what are your areas of specialty, and perhaps what do you expect out of the session today. Yeah, over to you, perhaps Dr. Sarah.
Okay. Hello, good afternoon, everyone. Thank you, Ami, for the nice introduction. So my name is Sarah Adrina, so you can call me Sarah. So I'm one of the founding members of Doctors on Ground, and so honored to be here. And also, I expect for everyone to learn more about the inequality, access to healthcare happening in our country. And also, I would like to learn also from Dr. Isriyanti and everyone here. And also, my interested topic is also refugees' health, and as well as women's health among refugees and marginalized communities as well. So yeah, that's all from me.
Thank you, Dr. Sarah. Nice meeting you. Okay, Amir, thank you. I would like to say thank you for Charisma Movement for this lovely invitation. My name is, you can call me Yanti. It's probably easier because Isriyanti seems a little bit tongue twisted. So I am actually a general practitioner from 2005 until now. And since 2017, I have actually started full-time teaching in Perdana University. I'm also actually quite passionate about education because I feel if we want to improve anything, education is the key. Along with that, I'm also involved in educating our primary care doctors with my involvement with Academy of Family Physician of Malaysia. I feel primary care is actually it's a very robust healthcare depending on the primary care, because as our previous speaker just now, Dr. Lee, mentioned, it's actually cheaper to actually work through preventive care and primary care rather than actually treating patients when they land in the hospital. So I hope this discussion would actually probably shed a light, the importance of primary care, and probably talking a little bit contribution about the health equity we are trying to address today. Thank you.
All right, thank you so much for the introduction, Dr. Sarah and Dr. Yanti. So I think, yeah, that's a good point on educating the population. Now, I think first and foremost, the aim of the session is to dig deep into why equal access to healthcare is important, no matter what nationality. Especially Dr. Sarah has worked with refugees, so as experts in the field, perhaps you can shed some light as to why it's important for the wider population to have equal access to healthcare, and what is the wider implication of not providing equal access to healthcare across the community. So the wider implication on people who have healthcare as well and whatnot. Um,
Okay,
yeah,
can I go first?
yeah, of course.
All right, okay. So I think the access to healthcare is very, very important because why is it important? Because it's a part of human right. And in this context, refugees is a human being as well. So I think this is a basic fundamental concept that we all have to understand, that we have to grasp. Like, so it's not to say that if the refugee is not a citizen of this country, then they shouldn't have any like basic rights. So the access to healthcare should be when the health services are available, then it should be able to be accessed by refugees as well. And I feel like why the wider implication, for example, we take like COVID-19. So if the virus, like, you know, if we don't like deny, if we deny them from getting not just access to healthcare, but also quality healthcare, um, it's more like more spreadable, the diseases are more communicable and all that. So I feel it's very, very important for us to address this issue and give them the equal access to healthcare, as is have very much wider implications on it. So yeah, I think that's my opinion on this. So Dr. Yanti, do you want to add anything?
Yeah, thank you, Dr. Sarah. Actually, whatever you have mentioned is actually on my this piece of paper. You have actually shared a common topic. I agree with you. Whatever happened during the COVID has actually tell us nobody is safe until everybody is safe. So if we actually seclude some minority or some population, then we actually feel that we are still not safe because they are still uh, be able to contribute and harbor the diseases, and it will actually still impact the rest of the population. And I also agree that why we have to cover everybody, because this is a part of human rights. As doctors, we should not actually discriminate whether you're financially stable or you're financially unable, whether you got paper on your on in your purse or something like that, whether there's a proper documentation. Health is a basic need for everyone. Yeah, thank you for that. It's actually quite sensitive issue to talk about. Yeah, why people have access and why people do not have access. But I think it's good to talk about it. I think it's good to spread so that everybody would actually start do something about that.
Yeah,
Yes,
of
and
course.
yes, true,
Yeah,
true.
Dr. Sarah.
Oh yes, it's true because like in along as we going down, so I think I'm gonna share like a bit of experiences and things about inequality among refugees happened that we handled before. So I feel like we can all learn from it and actually know that it's really a big gap considered not comparing the refugees and also normal average Malaysians like us, you know. So yeah, pass to
Okay,
you.
we would definitely love to hear more about that. I think Dr. Yanti mentioned about education and also, preventing diseases before it is happening. So, recently, our health minister made a statement that Malaysians generally eat unhealthy food, and the data backs that. The common cause of mortality among adults in Malaysia is due to cardiovascular diseases, and that also comes from lack of exercise, lack of diet, and whatnot. So, do you think that the status in society affects the eating habits of these groups of people? And perhaps what could be done to help that? Health correlates with income and whatnot. So what else could be helped? What else could be done to alleviate the problem of eating unhealthily and having cardiovascular diseases, for example?
Okay, thank you for that question. When I was growing up, I grew up in the kampong. You don't really hear people have diabetes, hypertension much at that time. This is I'm talking about 1970, so you can guess my age. Okay, we are talking about heart problem is orang kaya's problem. We were talking about, if you got diabetes, heart problem, that means you are kind of someone who actually have opportunity to buy food, but that is no longer true now. If you see the poverty and the poor people also have diabetes, heart attack. So it is actually no longer the privilege or the cream of the society's disease. We were talking about why do poor people also having all this? Is it because they don't eat properly? I would say yes. If you talk about healthy food, you go to the supermarket for the healthy food selection. No added sugar, less fat. The price is not cheap. Okay, go to buy a fresh produce, Jaya Grocer as compared to the market. It's expensive, meaning to say a healthy food is expensive, but a cheaper food is all carbohydrate laden that give you instant gratification, can fill up your tummy, and the price is cheap. So I would say it's not just about they don't eat proper food. I think probably they can't actually afford a good food, a healthy food. And it's an open secret. Yeah, when we were actually talking to people with chronic non-communicable diseases in the clinic kesihatan, we talked to this uncle or auntie about oats, adding vegetables in your diet. And to my surprise, they say, "Oh, doctor, I can't ask people to add more vegetables. They will increase the price of my noodles." So I was like, "Really?" And the nutritionist will say, "Okay, have a healthy diet of oats and all this stuff." And they will look at us and say, "What is oat? I've never seen oats." So, yeah. So if you ask me how to actually prevent this, again, it goes back to education. Prevention is the roots of everything. And it doesn't mean that healthy food is always expensive. I think with education, we can actually teach them there are actually affordable food, which is also healthy, and how much to take and how frequent. And, the education about the healthy lifestyle is also very important. Primarily, when we were in the kampong, people eat pulut and, all this carbohydrate, sugar. And after that, they plow the land and the soil. They sweat it off. But we just sit here, look, you and me sitting here, we just move our little finger and these muscles for mastication and oral. So that's how much we actually burn our calories in it. So yeah, there's a primary prevention, there's primordial prevention, and I think health in the mother is important before we actually breed our uh, offspring. So when we talk about prevention, it's actually started from the mother itself, and then children's and the rest of their life lah. I'm not sure. I hope I answered that question, Adam.
Yeah, definitely. Thank you so much, Dr. Yanti. So it comes down to economic issues as well as the healthy food being inaccessible. Uh, you know, let's just say the unhealthy food is more bang for the buck. Lah. Yeah. So it also goes back to education. Like you said, we have education in school, the food pyramid and all that. I don't know how updated is it to current times because I've left school for quite some time. So yeah, perhaps Dr. Sarah can shed some light into what you see on the ground regarding eating less healthy food. Perhaps when you deal with the refugee communities, what kind of diet are they exposed to?
Okay, thank you, Ame. All right, so talking about on ground, of course, our name is Doctors on Ground, so we go on ground a lot of times, and we are very close with the community. So we basically know like not everything, but mostly everything. So the main problems when it comes to this kind of disorder would be like diabetes and also obesity, but mostly diabetes. But it's not just the food. They don't have proper education that food play a huge role in our daily life. So they eat whatever they can. And also because of their financially struggling, so they whatever like we try to incorporate like good healthy food when it comes to our food distribution, just to educate them. Okay, this is okay. This is bread, so it gives you carbs. So we're trying to educate along the way. So it's one thing is this kind of disorder like diabetes is very common in our community. And the second thing is they don't have proper education when it comes to this, and it's very, very saddening. And they just eat whatever their husbands bring back. So, and they have to share. So, when it comes to sharing food, like they have 5 to 6 kids, one household, like mostly. So it's when it comes to sharing, they don't have a proper proportion of, the daily energy intake, I think. Like, so this is a problem as well. And third thing would be it's not just this kind of on ground issue that we have. The third thing would be I just want to shed a light on like family planning. They are not aware of this. They are not aware of how important um, sexual health is. They don't know what is um, condoms, contraception. So they like get pregnant every time. So it's a very hard thing to talk to them about, because these on ground issues that we have, it's very, very challenging. And they're really not exposed to this kind of things, so hence it's an issue for us as well. So that's what I could tell about like some of the on ground issues that we have when it comes to healthcare and also other aspects as well.
Yeah, thank you, Dr. Sarah. I think the lack of exposure to sex education not only affects the refugee community, but it also affects Malaysian communities as well, as how it's seen as a taboo. You know, like you're not really allowed to talk about contraceptives or anything related to sex in school at all, in government schools at least. So, just following up on that, perhaps what are your hopes lah, as to how the government or maybe the education ministry can incorporate that into the curriculum, and how do we combat this taboo of talking about it?
Okay, thank you. All right. So as what Dr. Yanti mentioned, everything comes to education, back to the soil again. So it's like education first of all. I think government should like incorporate this into the syllabus of our education. I feel like I understand that this is a very sensitive topic, but also it's very, very important, because for example, if every time I go on ground, I'll talk to the women, young women like below my age, like 15, 16 years old, but have 5 to 6 kids, and they're not like aware of this. It's not just the refugees, like also our average Malaysians, right? So but I'm trying to like emphasize on our community, because they're not being paid attention so much. And it's very, very pitiful that they have to, there are so many constraints when it comes to this. It's just like 5 to 6 kids, and you're so young, you're not aware of like sexual transmitted diseases, you're not aware of like sexual health, also women's hygiene. They don't know what is reusable pads. They don't know what is tampons. They only know like normal pads, but they have access to that. It's just that sometimes we also come on ground and distribute pads to them, because this, like, I think this is very, very important, not just for the average Malaysians, but also for the refugees. But when I talk about average Malaysian, it's important for us as well as women to have and know this sexual education. So I feel like government should put it into education, just incorporate it into the syllabus. I know it's very hard and it's a very long process to just filter everything, but at some point we just need to do that, because so many people are not aware of this. Even in my like circle, they're not aware of like transmitted diseases. They don't, like sexual health is just being ignored. So yeah, I think Dr. Yanti, you want to add anything when it comes to this?
Thank you, Dr. Sarah. I agree about the lack. Actually, there is a sexual education at school. This has been ongoing almost 10 years. The LPPKN and the school have actually started the ground running. But I must say there's a lot of limitation and successful story out of that. I suppose there are a lot of hush-hush issue because I think one, the module is there. Number two, the teacher were not being trained how to deliver that. And sometimes there were an occasion where the doctor, like a primary care doctor, come for a talk to the school. And the teacher will get a complaint from the parents because the parent will say, why are you teaching my son or my daughter about, oral sex, condom, oral contraceptive? So I think when we want to implement sexual education at school, I feel that we have to involve the government as a policymaker. Number two, involve the teacher, train the teacher. And number three, we have to involve the parents. Because I think if the parents are not involved, even though we actually give a very good module at school, the conversation with regard to healthy sexual education stop there. It doesn't actually continue at home, and most of the time, I think learning, building up an attitude, or the way they shape a future generation starts at home. So we have to actually involve the parents. And obviously, while creating the module, it should be sensitive enough to the culture and religion, but it should be accurate as per what we have to cover. Because I think the informations about education, about sex or sexuology is available everywhere. It's at the tip of the finger. They can get it. If the parents do not talk about it, somehow, somewhere with this era, the children can get the information. But how accurate is that education? How much that actually decipher in their mind and what actually came out? What information that they gather and how it shaped their thinking? That will be questionable because there is no guidance. So yes, sexual education at school is very important. You can start from they were toddler, age appropriate, what is safe touch, non-safe touch, stranger danger. Then once they go to the primary school, a little bit more about biological, and then about the sensitivity about gender, and then non-discriminating about boy, girl, in between, and people are talking about LGBT. I think that's very very important to actually discuss in school so that they don't become discriminate between boy, girl, someone who do not want to be identified as a boy and a girl. And when they go to secondary school, they can talk a little bit more about prevention, how to keep safe, how to trust, and how to respect people. And we were just having some other webinar with IMU just now talking about prevention, safe sex in Malaysia. And this is actually adolescents who are actually getting pregnant because they're hiding. They don't know how to do or have to look after themselves. So that's actually a big issue. And I think the issue starts at home and actually can be tackled at school. And as primary care doctors, we actually seeing cases, and most of the time, it is not actually limited to any particular race or what we call that some sort of population barrier. This is actually a general and universal problem. I think we need to educate our children about safe sex. Thank you.
Okay, thank you, Dr. Yanti and Dr. Sarah. I definitely agree on your point regarding parents playing an important role. I volunteered with Charisma Movement before, and when teaching, um, the students who have more parent involvement have higher grades. So there's a correlation between that. Yeah. So it's very important, and I think with the COVID-19 pandemic, for a year plus that students did not go to school, parents played a more important role at home. So I mean, education aside, so COVID-19 without a doubt like exacerbated the healthcare inequality in Malaysia. So to the urban poor, to the rural areas, or even the refugees itself. So it definitely revealed the flaws in our healthcare system as how I see it, which would never have been revealed if this is business as usual. So perhaps being in the healthcare sector, Dr. Yanti and Dr. Sarah, dealing on the ground and all that, what are the major flaws that you see in our healthcare system?
Sarah, you want to go first?
You can go first also, doctor.
Okay, our MCO starts March to 2020, right? 17 March 2020. It was 3 days before my daughter's birthday. So we had to cancel everything and everybody like, oh, okay. Then after that, as a primary care, fortunately at that time, I was not actually a fully practicing GP. I was actually a teacher. I'm a lecturer, so I can learn how to teach people online. But for my colleague who were on the ground, that was the most difficult situation because they were not sure how to actually address this. And there was also, everything becomes so magnified that you are in public healthcare system and this one is in the private healthcare system. There is no, how to say, amicable communication at that time. The public health and the MOH is actually dealing with the situation. They're actually looking after the pandemic on their own. And the GP, we have so many GPs in Malaysia, right? We got about 6,000, probably more, at the health clinic. But they were not sure what to do. They don't even actually able to open their clinic because they're so worried because they don't know how to react with this situation. And having said that, in our chat group, they said, hey, where to get the mask? Hey, where to get the glove? That is not there. And true enough, everybody's asking me, I want to get a pair of gloves. I want to get a mask. I asked all my pharmacists, there's no stock. So it shows so how unprepared we were for the basic PPE, just a mask and the glove. I'm talking about the initial part of 2020 when a lot of people were actually trying to get food, brass, everything, gardenia for that matter to their kitchen. And the doctor were thinking, oh, how do we actually protect ourselves? Is it safe to open this clinic? To see patient because we at that time we do not have all this saliva test kit. We are not sure how bad is the infection. So some of them actually just closed their clinic and they actually lost the financial, the income. And at the same time, we were wondering what happened to the patient. Yeah, we are just talking about patient with chronic diseases just now. So who monitor them? And patient also were so scared to go to the hospital. So there were a lot of patients, not just a stable chronic diseases patient, there were vulnerable society population that were say, oh, this is a high risk cases, you should not come to the hospital. But then they, at the same time, they were not being looked after. So that was a very difficult moment. Patient with dementia, children with a special need, those who need rehabilitation, they were so difficult. We do not know how they actually favoring during that difficult time. And obviously, we have a lot of uncontrolled diseases. They probably getting more and more difficult to control because they are actually not having people to access to the healthcare at that time for a short time. So if you ask me again, what are the flaws? I think our preparedness for any calamity or health emergencies, probably we learn we need to be better to deal with the situation. Number two, I think the flaws that I think in between normally in Malaysia, the two-tier system, the private and the public, I think we need to have a better communication and learn to try to work with each other to actually improve our population for the health access. I think we are all learning. I think some good thing that has happened with COVID is actually the government can actually utilize the private sector for the better care of our own nation. Sarah can add a bit more.
All right. So thank you so much, Doctor. I think that's a really good point. I mean, that's the major thing, which is, I think, one of the major flaws that should be addressed is the unpreparedness when it comes to this health emergencies. That's a very, very solid point. But I want to add a bit more when it comes to one of the major flaws that I see is basically our healthcare system is massively underfunded. I think that's the truth. Underfunded, under-resourced, and also lack of appreciation, I feel. Not just I feel, but also my colleagues as well. For example, we take Hartal doctor contract. That's one of the major flaws I see. How you want to work from that, how you want to achieve a great things when it comes to our healthcare system if your medical industry, your healthcare workers are frustrated. I'm frustrated as well. So I feel like the lack of appreciation is a flaw as well. And for example, my second point would be there are too many refugees, but the government, I feel like lack of a solid, concrete policy when it comes to managing them, when it comes to health care. And because of this, hospitals as well do not have a solid, concrete policy when it comes to managing refugees as well. So, for example, recently I had this one patient where we handled, and I can mention the name, but so we brought her to this one hospital, and she was being denied when it comes to this because she's the person. We want to get her to get admitted, but then the workers said that she's not severe yet. The symptoms are not severe. And then I was arguing with I was frustrated because we all frustrated because how bad you want her to be just because she's a refugee, just because she's not a citizen of this country. I feel like that's a major flaw as well, because why are you being discriminatory? This discriminatory issues happening. Why you discriminate them just because they are not citizen of our country? Is it like that? So I feel like there's no strong policy to just uphold our duty of healthcare system. So yeah, and the third one would be stigmatization, stigma. We're still stigmatized when it comes to healthcare, these discriminatory issues, barriers that we have. So yeah, I think that 3 points are good enough to conclude my points when it comes to flaws that I see in our healthcare system.
Mm-hmm. All right, thank you so much. Yeah, so that really shed some light, and yeah, I think that's while certain countries were more prepared than some at the start of the pandemic. So, for example, South Korea, they were very prepared because they had the experience dealing with MERS, I think in 2013 or something. So they already had contact tracing in place, and so they know what to do. But Malaysia, despite having faced numerous pandemics, right? Yeah, H1N1, the bird flu and whatnot, we were not prepared. And perhaps that also ties into the fact that we are underfunded and under-resourced, like Dr. Sarah highlighted. One more flaw that I was interested that Dr. Sarah highlighted was the discrimination towards refugees. So you said that there's no policy when dealing with refugees, right? Is that right? Yeah. Okay. So in the case where a refugee wants to get healthcare, so what do they do and where do they go?
So this, according to our, based on DNG's experience, that they will complain to us. So we have case workers. So case workers, we have case workers who are not just medical volunteers or doctors. We also have non-medical volunteers who are actually case workers. So we go on ground, we go to their house, get their medical history, because they have none. They have none of that. If you ask them anything, they don't know. So because they're not educated on this, and they're not aware of I just feel my pain for years, for example. So we come and then we go on ground, we do medical history. It's the doctors will check up, and medical volunteers or non-medical volunteers will help assist the doctors, and then we'll bring if one of the doctors will get so for example cardio diseases or what. So we refer them to a GP or a friend to the doctor. It's herself. So from there we contact other specialists, and then the specialist will refer them to nearby hospital, and then we go to the hospital, and sometimes, like we wait for like 8 hours just to get them admitted, because it's a very hard process, a long process. And we face, we always like argue, and like argument will happen. So it's a very like tension, like stressful thing, not just for us but also for them, because they were just worried and sitting there for 8 hours waiting with us. So yeah, I think I hope it answers your question, Ami.
Yeah, definitely. So I can imagine that, based on what you say, that they really rely on NGOs, then there's no really any proper mechanism in place for the refugees. Not even the illegal refugees, even the legal refugees can't get help, right?
Yes,
Yeah.
true. And also they are scared of being detained or like arrested. They are scared of that. So we just want to avoid that. We just don't want to instill more fear in them. So having the illness itself just, very scary for them. Like getting
Yeah.
arrested just to seek help, medical help, is even like fearful. That's why they say, oh, it's okay. We don't want, whenever I ask them, okay, let's go clinic and all that, then they say, it's okay lah, kak. I don't want and all that. So because they are scared, just because they're worried they're having illness, but so they're worried of their kids at home if they get arrested. So yeah, it's one of the
The
main
fear of being
things.
deported is even worse than the disease itself. Uh, right. Thank you for that. That really sheds light on the reality of healthcare in Malaysia. So I'm just curious. We had a bit more from Dr. Sarah. So, Dr. Yanti, in years in your field, in as a GP previously, I know you're teaching now. Have you ever had to turn down anyone, or have you ever heard of anyone in perhaps your circle or anything being turned down seeking medical attention?
Okay, to answer the first question, fortunately, no. Okay,
Okay, that's
I have not have opportunity, which is thank you God that I don't have that opportunity. But mainly, when we were in healthcare with the Ministry of Health in KKM, we were actually in the ward, that we were not actually at the admittance that registration area. So
okay.
if there is turning off of the patient, it was not done by us doctors. So we have no opportunity dealing with that. So what happened at the registration counter is probably beyond our awareness as a healthcare doctors. So I will not be able to say things are not happening. Okay, so that is actually my own personal experience. But I knew they are not only UNHCR or refugees who will have challenges or barriers in accessing healthcare. There were workers, sometimes undocumented workers, or sometimes people with documented workers
Yeah.
too, but the passport has been held by the majikan who was probably 100 miles away. So even if I saw them in a GP clinic where sometimes currently I work, and you make a referral, and then you need tertiary or secondary care in the private or government hospital, they will not go. So if I call them, have you actually get the treatment that we were suggesting? They said tak adalah, no lah, we don't go. And there are two reasons why they don't go. Number one, obviously, is finance.
Yeah.
Okay. Number two, there are other reason, because if they go, they will lose their day or two income. So that's 10 ringgit, 20 ringgit of their income meant a lot to a lot of this foreign worker, because they are salaried by day. So that's why sometimes when I see them in Klinik Kesihatan, was I was doing my gazettement, if they said that I need a day leave, I just give, because I will not scold them, oh, you malas kerja. That is not the issue. They were not well, and they actually left half day or one day of their own salary for that day. So that meant a lot. So, but even though I have not turned down a patient, I would not say that's good. There are other things that, we call it accessible healthcare. There are patients who are already in front of me, but I was not able to treat them because the facilities, the expertise was not there. Okay, if you work in a district hospital I used to work somewhere in Kelantan, yeah. patient travel so far away from a remote area, rural area, maybe near the jungle area. They come to the district hospital. We say, we are very sorry, we don't have this sort of treatment. They probably need tertiary or secondary care. Then you need to send this patient to either USM or hospital, the Central Hospital in Kota Baru. So if they're sick enough, we send them through the ambulance. You think about logistically how much, a mileage they have to travel, and they came unprepared. And the next time, if somebody's sick, they will just not go to the hospital because they have so much bad experience of accessing the healthcare that they want. They would rather stay at home and redha je lah apa nak jadi, they will say like that, I just take it because getting health attention is a bit too much. Okay, I can go on and on, but I think there's a lot more other questions that's coming. Okay.
No worries, we will circle back to that, of course. But I'm just curious, you mentioned that you worked at the district clinic, right? So I think just moving on to the next question then. There are some structural determinants, in particular housing. I mean, we spoke about income and all that previously, right? But where specifically you live in the country kind of determines your access into healthcare. So you also mentioned that people in rural areas need to travel so much further just to have that healthcare, and sometimes they can't even get that. So, in your point of view, like, how is the GP access in different parts of the country different, and perhaps how bad is it? Speaking crudely, yeah.
Okay, all right. When we call it the barrier accessing the healthcare system, the barriers are not only one, okay, and it's not just logistic. If you talk about Sabah, Sarawak, or remote area which is not in Klang Valley, distance play a part, transport system play a part. That is definitely true. Even though not the only thing. I think health literacy is also very much important. Meaning to say, even though you are actually in Kuala Lumpur itself, I have actually have an opportunity to join this house to house to give vaccination to patients who are actually unable to commute to the PPV. Okay, and you must say, the inability to access the healthcare, even though it's just one block away from your home, it's not because it's just a logistic, the distance, but the patient was actually disabled or unable to walk. They were in an apartment with no lift. They have to walk down the stairs, and they are not able to come down because they have no assistant to do that, and they are physically unable. So if you ask me how bad, so we cannot pinpoint only one area. Okay, Sabah, Sarawak, yes, this is known. Much needed to be done. If you ask me, GP clinic also that not many there. I guess a lot of Sabah and Sarawak people rely a lot on a publicly funded clinic to access healthcare. Yeah, I guess whatever need to be done is actually government has to actually improve, send how many doctors that newly graduated every year, about 5,000 newly graduated doctor. They could actually be sent to this rural area, develop the rural area so that the healthcare become accessible. Because I think, remember what I said just now about the patient who come from the jungle, from the remote area to the district hospital, travel so far. And then if they have to travel, if that is very critical, we might lose the patient because that time to get the tertiary care that they want is actually there. If we can actually do that, allocating the healthcare facilities to this remote area, or probably we can actually send some doctors or expertise to that particular health area, would actually have a better coverage. The idea is not just GP. I think the government have to work with the GP. We all have to actually play our part, I suppose. GP have more clinic, but it is actually probably more located in highly density the highly populated area. We don't really have GP clinic in a very remote area. I think it's talk about how many coverage, how much a business a doctor can earn. So I think that is the reason why. Yeah? It's not that the doctor doesn't want to go there and then establish a clinic and give the service. There are a lot of altruistic doctor that would like to go there. But when you talk about private practice, obviously there's a little bit of business mechanism have to come in place. So the GP is actually in only the area where the population is actually quite high for the business to carry on.
Of course, yeah, that's understood. I mean, the doctor take on the costs and all that, and they need to provide the living. So it falls on the government to provide the facility in these areas. But okay, thank you so much for answering that, Dr. Yanti. So I think perhaps talking about private practitioners and all that. Dr. Sarah, do you have anything to add on the previous point, perhaps? Any thoughts?
Yeah, I
Any?
think I think Dr. Yanti like covered a
Okay,
whole
okay.
lot of things, so I think it's good.
No worries. We have more questions for you. Uh, right. Moving on to, I mean, yeah, moving on to the, since we're talking about private practitioners, right? So Malaysia has perhaps one of the world's best two-tier healthcare system, or private healthcare system for that matter. And we also have this two-tier healthcare system where private and public healthcare exists together, right? And recently, Singapore's investment fund, sovereign wealth fund, also invested in Sunway Medical Group. So there's a lot of money in our private healthcare, but it still remains inaccessible. So for normal people living in urban areas, perhaps they can afford insurance or maybe have good jobs that cover these. But for the majority of the population, or even refugees, especially refugees for that matter, it's inaccessible. I mean, due to the steep fees and low insurance penetration. So, um, not speaking from the policy side, but perhaps from your point of view, what do you wish to see being implemented to increase access to this private healthcare, which is amazing?
Okay. Thank you for that question. Like what you mentioned just now, like it's very, very differ from us average Malaysian. Like, we have insurance. We are able to reach out to the nearest hospital, clinics to get our medical needs or treatment. But for them, it's very, very like a big gap from us. And like my first case with this one patient was really like I was shocked, I was speechless because the patient, because of not the timing, like because what Dr. Yanti said, the time to just reach the hospital itself could be like a life-threatening thing, so that patient like died, like passed away because the time. And it's very, very saddening. It's just that the moment that happened, I realized like how important the access to quality healthcare is. I was like, my passion like grew stronger from that. I was like, wow, like it's just different from us, like we can just like call and like the ambulance start come to our house, but they have to like reach to us, like go through that like just multiple process just to get admitted. So I wish that there would be like a concrete, solid policy from the government when it comes to just not dealing with our, for general Malaysians, but also like marginalized communities, refugees, B40 families. They need that. They need help. And not just of that. Also, I would love if like one day we could have this. I know this will be a long, long time process, but like this social stigma, this taboo that's happening, like, and I feel like there should be a policy where, okay, how to train our medical professionals or medical workers more on like treating these people, the marginalized communities. I feel like I will keep learning about this, even though I'm in this communities. I would love for like our own hospital system, healthcare system to just train us when it comes to dealing with these kind of people, because you will have language barriers. There are so much barriers when it comes to them, and you need to a whole lot more empathy when it comes to talking to them, just to get the whole medical history. So yeah, I think that's all from me. Dr. Andy, you want to add more?
I will just continue from where you stopped and then get back to the original question from Amir just now, talking about the barrier of the refugees. It stems sometimes the language and the access. I agree with you. I think we need to actually probably have a better education to our own healthcare provider, how to deal with this special population, the vulnerable people. The way we actually address their issue, the ability to understand where they came from, because health is not just about the disease. This is what I always share with our doctors, our students. The health just don't come on its own as a disease and anatomy in your own physical being. It comes a lot with a package of social determinants and your psychology, the health issue. So it is actually a package of your biologically and physically, obviously, but it's also have a mental health that affecting it, and the environment from where you come from. So this actually shape who your patient is. So if we just look about the symptom only, we will not be able to treat our patients. Ability to understand what actually go beyond the disease plays an important role in actually treating the patient. And I agree with you, we are underfunded. Our GDP for healthcare is about 4, now actually going to 5%, where WHO is actually wanted 7% GDP, probably is gross domestic, contribution to the healthcare by right should be about 7%. But how do we actually make the better access of a population to private? The first question. I think government has actually started something that we talk about. If you have heard PERKA, there's something that they offered to the bottom 40 for the access of screening through the GP, and there's a My Salam program also by the Great Eastern, where people of a B40 community can actually claim for their admission to the hospital. This is actually free. There is no taxation. But something more about this, I think a lot of population, they were not aware, and they because they don't know about it. The system is there. There's some allocation of money, but it could be better. But I feel if the government is actually keep giving, it's probably something what we call unsustainable. Meaning to say we can't give free service for everything. Taxpayer money has to be actually put in there. But I suppose healthcare getting more and more expensive, and the divide is getting more, because if you have financially there's a barrier, you probably won't be getting the higher cutting edge of treatment, even though you come to the hospital. This is what happened in the government hospital sometimes. There will be a nice pensioner uncle who was saying, I have diabetes, I want this sort of medication, because he knew this is the best treatment. Then we have to say, I'm sorry, this is not available in the klinik kesihatan, because the allocation is not there. Okay, so basically, how do we address this? The healthcare system is there, but it is not unable to fund everything. So probably people have been talking about who will contribute to the healthcare. Is it just enough 5% of GDP to actually support for the whole nation of publicly funded, or shall we actually ask everybody to contribute a little bit to the insurance care for everyone? So I guess this is a very long, big topic, but maybe Amir on the economics could actually answer that question, how to address that issue. Americans has been talking about it, about the Medicare and stuff like that. Obama has been talking about accessible healthcare. So, but it's actually worth talking about it. What I can say in Malaysia at the moment, we are happy that from 4% it goes to 5%. Let's hope our current minister will actually do a bit better. But between public and private partnership, that's very, very important. And the ability of public means population to actually access the private healthcare through MySalam, through Perker, is actually one common, I would say, pilot project that the government say that yes, we can utilize private healthcare system to actually help the population. But unfortunately, I must say, Dr. Sarah, it doesn't cover your minority refugees population, and it also doesn't cover uh, our foreign worker who are paperless, or who does not have documentation. So how to address this issue? I am sorry, I won't be able to help find the answer, but I guess if we keep talking about it, maybe some solution will come for that.
Yes, and I feel like everything starts like small. So we're trying to gather the effort to just keep on like pushing this issue. Um, yeah, but one of the like example of like experience that we had was that because of this like no insurance, like this like lack of access to healthcare, like one of the patients, like even for the wife, he borrowed like a loan shark or something. So it's very, very saddening for me. You know, like it's just like a very like saddening situation where we couldn't like we can only like fundraise, but we just want to push. We cannot like push this issue like, oh, insurance or what for them, because I know it's like, you know, it's not like we can't just like push everything to the government or what, but it's just like something that's very like worrying, saddening, but we can't do nothing about it. But also in DNG, we're trying to push this issue more, like for people to get more, for people to be more educated on this current thing, and also for the betterment of our communities that we care for. So yeah, Ami, do you want to add anything when it comes to this economics or something? What's your 2 cents on this?
Well, my 2 cents on this, it's a very tricky situation, I would say. From my point of view, I believe that it should be funded by the government. Yeah. Like all in all, I mean, I don't mind paying. I mean, I do believe in somewhat like the NHS model, where I mean, it also has its flaws, but um, there are more people being covered than not. At least they have access to healthcare despite its flaws. Yeah. Um, right. So that is that. But of course, perhaps okay. Circling back to the flaws earlier, right? So this, without a doubt, is one of the flaws, lah, perhaps. Um, but maybe do you have any uh maybe model country in your mind right now on how our healthcare system should be structured?
Too
Anyone?
hefty. I think you can like express this a lot better than me. Maybe I can add a bit.
I just want to add about what Amir was saying about the NHS. NHS was the model before,
Yeah.
because I think they're very good, and then they're actually very strong in terms of primary care. But lately, there's also having some issue. A lot of fund has been cut down. As I mentioned just now, you cannot actually have everything by the government. You cannot provide everything for free, because I don't think economically is sustainable.
Yeah, of course.
So basically, I think we all have to do our part. People have to be smarter. If you are actually a majikan with like 1,000 or 2,000 workers, you have to actually insure your workers. I guess that's how to go about it. And then we were talking about policy for the healthcare. The government has to give some allocation for those minority, for those who are in a vulnerable situation, for patients who need rehabilitation, special children who has a lot of barriers to even come to see the doctor. I think if there's a solid policy for them, I think those people who have no voice could actually come, because if the community actually know about this, they can actually, you don't worry, even though you don't have document, there's some special way of you to get this treatment. So people will not shy away, people will not actually suffer silently in their house or in their care home, something like that. But it's if you ask me a model, I have not studied which model is best, but
Okay.
NHS model, the previous one probably was actually what we're trying to emulate. I am not aware what models in Hong Kong or Japan, Korea, but I guess they are very good in terms of planning and executing their healthcare system. I guess we have to look into that and then see how to emulate or how to actually learn from their efficient healthcare system.
Just to add a bit from what Doctor said, I have the same thought as well. I mean, NHS previously was one of the best in my mind. Like the way they handle, execute their plan, everything is just smooth. Also, it's not to say that we need to compare with Singapore or what, but just like to emulate like how they handle the healthcare system. But to just copy like bulat-bulat is not sustainable, and so like
Yeah.
it's just not you cannot like get samakan with us because we have wider, bigger and different population than them. It's just that just to emulate like how New Zealand, Singapore healthcare system is, I think that would be like a great thing for us to just look up to or emulate from. But yeah, like what Doctor said, NHS UK was one of my like very interesting like healthcare model that we could see. But now they are very like their funds also like being cut in so many aspects. So yeah.
I think Dr. Lim touched on the public sector waiting time just now. Yeah, in NHS in the UK, it's quite, waiting time is horrible. If you break your leg, then you'll probably just wait for many hours.
They
Yeah.
even showed it in like Netflix series when it comes to NHS. So I saw like a lot of like movie where they go hospital and they address this kind of issue like sarcastically. So I was like, wow, that's very people are just frustrated on that.
Yeah, that's true. That's true. I think uh one model that's worth highlighting is the Taiwanese model. So they have the National Health Insurance Administration, where it is funded widely through the payroll of the country. So basically, the government is the insurance sort of. So it's a sort of a universal healthcare system, but funded by the government through taxes per se, insurance premiums from the payroll. Yeah. But yeah, we would probably never know until we try and error, and make probably several studies in this. All right. So perhaps moving on to the next question, just more on like sharing experience. Uh, you mentioned about Dr. Sarah mentioned about working with vulnerable communities. Other than refugees, who are the other vulnerable communities do you work with? And what are the challenges that you face when reaching out to these communities? I mean, you did mention on them afraid of going to the hospital and whatnot, or perhaps any other challenges that you could shed the light on?
All right. So, who are these vulnerable groups? I would classify them as refugees and also B40 families, according to who the NGO work with. So, we work with Rohingya and Myanmar refugees mostly, also B40 families. Why are the refugees? So, first, why refugees are classified under these vulnerable groups to us is because of their status. So, because of their status, they don't have access to like proper jobs, education, hence the healthcare system as well. So their healthcare is being jeopardized because of that. Okay, so the next one is B40 families. As we all like understand, they are financially struggling. So hence this is why we consider them as like vulnerable group that we work with as well. So when it comes to challenges, I'll break it into like three layers. So like, the first one is financial. So when it comes to financial, like these vulnerable groups they don't have proper access to quality healthcare. Hence, they have to pick and choose. So, for example, like in our experience, like in our case, one So the husband, for example, so he's sick, but he also need food for their family. So she have to pick and choose whether they like food or medications. Both are important because medication is sick. He needs to go to work and provide for the family, but food, he needs energy as well, and also to feed the family. So it's a very, like, you can see like this challenge that we face. Like, we just need to educate them on this. And then the second one would be convenience. Convenience, as in just community is very far from like clinics and hospital. So sometimes, for example, one patient need to clean wound or post-op surgery appointment. So they have to push the appointment date to like further from the actual appointment date just because it's not convenient for them, or they have to like tumpang someone to just go to hospital, like, and we have to just to reach out to us, we need to like rent a van or to bring them to clinic. So we just need to like, okay, who any volunteers free to, because everyone is like working, and sometimes also I try to like, I can't wait to just go on ground and like do it back again, because we hold a bit like casework before due to pandemic. The third one, which is very, very important, is education. So first one is financial, convenient, and also education. These challenges because, for example, family planning. It's very hard to talk to them about family planning because they don't have proper education when it comes to this. About sexual health, like family planning, as in when I did survey and talk to the young women, they feel like it's a God's blessings, when it comes to children. So like it's very financially struggling for them, but they also say to us that they don't want to interfere in God's plan and God's will. So it's very, very hard, just not just the financial part, but also to educate them when it comes to like, because you're financially struggling, we can't say that. So we need to like reiterate it in a proper way. So because of their financial, they can't like keep getting pregnant every year, like every 2 years. And somehow they're so young, like 15, 16 years old. They have 5 to 6 kids. And
Yeah.
it's very worrying for us. We just want to control the population a bit and just to, it's growing and growing. And like they have 5 to 6 kids, and all of them like very, very small, not just like not like huge age gap. That's the
Okay,
first
like
one.
very close.
Yes, and the second one is also communicating with their doctors, like with us. So because we don't have the entire like medical history of them, so like this one patient, we had like multiple visits with her until we realized that she has like different symptoms like for quite some time. So at last, after like multiple visits, we found that she has HIV. So she's not educated on that. She's not aware of this. So that's the first thing. And the third thing about education is that because these vulnerable groups are not properly like aware of red signs, red flags, when it comes to, for example, their child had fever or severe symptoms, so they're not like aware of this red flags, and then they like just ignore that for quite some time until it becomes really severe, and we have to like come and like do everything like urgently, So I think that's all. And the last one I want to touch about is diabetes. Like in our community, diabetes is also an issue, but they're not like educated on like how food like play a huge role in their life. So they just eat whatever like they can afford, and like they can, oh, this is cheap, so they just take any unhealthy food, and like the kids like get obesity at such a young age. So this is the three challenges that we face working on ground with the community vulnerable groups.
I see. Okay, thank you so much for that. Yeah, that really shed some light on a lot of the challenges that you face on the ground. Perhaps, Dr. Yanti, do you have a different perspective of this from perhaps your GP days?
Okay, I just add a little bit about vulnerable population and then challenges of them. When we talk about vulnerable population, it's not just about people who have no paper, no documentation.
Yeah.
Not just that. There are our own population. We talk about B40, and then the T40, and then so who's looking after the middle? Okay,
M
so there's a
population.
there's a lot of help for the B40. So the middle income group is it. So who's talking about us? And within that society of B40 middle income, 20 or something like that, or 40, the 20, 40, 40. Okay, the middle 40. It depends also. Uh, your hierarchy in the family. Who are you in the family? They become vulnerable if they were a wife with no access to transport or finance, or a children who the parents have neglect them because they're too busy earning money, someone who actually probably disabled and not being looked after. So these are actually someone who have a hearing disability, vision, people who have sensory barrier to actually go out there on their own, because you know how our road is so bad. You can actually walk with, if your vision is impaired, your hearing is impaired. So they actually shy away from the healthcare too. So there are a lot of other population that actually probably have challenges or barrier to actually come to get the health care that they needed. So I like to ask Dr. Sarah, sorry, this is a question from me. Is that okay, Amir?
Yeah, of course. Please.
You're talking about the family planning, there's no education, and then the poor actually having one kid after another. I just want to ask your opinion. When you actually talk about family planning, were these mothers accepting it, or they kind of, oh no, it's taboo, I don't want it, it is not good, or were they actually want it but it's not available to them? What was the ground situation, if you may?
All right, thank you so much for the question. I'm very interested. Like, I'm very interested in this topic. Like if I can do like a research soon, so I would like focus on family planning when it comes to refugee women. So basically, what happened is just they feel like children are God's blessings. Like they want a lot of children, but we always tell them like like in proper like way, financially is not like an okay thing for you, and also you're so young, there could be complications as well, right, doctor? Like it could be. So it's not that they're not accepting it, they just it's not that we they don't have any access to it, it's just that they don't, it's a bit hard for them to accept that, oh, I can't get pregnant, like provide kids for my husband, this kind of issue, and it's very hard to talk to them about this. So, but also because I'm working with like Women for Refugees as well, where we provide literacy program for the refugees women, like business entrepreneurship skill like this. So we also do like what call that, women's health workshop, like family planning workshop, just to educate them a bit on this. So we're trying to push that workshop more and more every time we go on the ground. So also period poverty. That's one of the things I want to speak up also. But they're not aware of sexual health, women's hygiene, family planning, apatah lagi, right? So I think like we in the Doctors on Ground, we're trying to like tackle this one issue per issue, like teach them about hygiene at first, and like sexual health, and it comes to like family planning. It's just like but it's just like taking time to just get them understand how important and how bad it would be, if they keep like not, they're planning it in a very good way.
Thank you, Dr. Sarah. The reason why I'm asking, because sometimes in our culture, in our society, when women are being advised of family planning, they'll say, nantilah ya, saya sembang dengan suami saya dulu. So that will be, they always feel that there's a need to actually seek blessing or agreement from the other partner. Sometimes we can see that the women struggles, and we feel so sad if the husband is not actually understanding the whole situation. Some men will say, oh, it is so not manly to be my wife to be going for family planning, something like that. I don't know, they somehow they have a different opinion what family planning is about. But I just wonder whether that is the issue in a vulnerable situation, uh, in a refugee, whether they actually
Yes.
subdued to their partner that I cannot make decision. This is my husband's decision, so that's why even though it's available, I will not do it unless he said so. She said yes.
Yes. Yes, actually, doctor, I forgot to mention that as well. Like whenever I did like talk to them, they were like, look at their husband and like, ask them in their language. So I just no, okay, so this is also an issue. But I understand it's not just happening like among the vulnerable groups. Like I also experience it like other than vulnerable groups also, like where they need to okay, I ask my also other patients, like general patients as well. Like, oh, I have to ask my husband this, and when it comes to family planning and all this, it's not that you can't. It's just that if it's a bit wrong because it's your body, right? But then I understand that. But it happened as well, doctor, in vulnerable groups where they just look at their husband whenever I ask, so I instantly know what exactly is happening. So I just advise her so it'll be complications. And it's not just this barrier, it's just language barrier where I need to translate to their friend needs to translate in their language, and then the person translate back to their language to their friend translate back to me. So it's a very 1 minute, not 1 minute, 3-4 seconds question could be 1 minute thing. You imagine if we did survey before of 10 questions, it took more than 1 hour. And what, for 2 hours I just talking about to 3 women. So it's just a very draining. Not just
Yeah.
I'm complaining. I love that job. I love it so much, just connecting with the women and how friendly they are. So it's just that it's very draining, as in the process itself, just to obtain the single information. So yeah, that's all I could say.
Of course, if you are looking after someone have to actually listen to you moaning and groaning, and because I think be able to voice that out is actually healthy for people who are looking after others, isn't it? So you are allowed to complain, Dr. Sarah. Okay.
Okay. Right, any more questions from Dr. Yanti, perhaps?
Yeah, actually, to Dr. Sarah,
Yeah,
to you
any,
or to
please.
you? Um,
To Dr.
uh,
Sarah, Health Community.
yeah, there's a question about mental health that you're supposed to share
Oh, yeah.
to Dr. Sarah. Maybe I'll just ask Dr. Sarah before that. Uh, I always admire people, who are actually involved in the NGOs, looking after children, looking after vulnerable population, and they also address the issue of this mental health issue. Yeah, and we all know after 2 years of pandemic laden, the health problem, economic problem, mental health has actually risen up. Domestic abuse, yeah, all this problem has magnified. But I always wonder, for those who care for others, I'm sure just now you said, when I talk so, a long-winded consultation, feel drained out. So if this healthcare or people who are looking after this vulnerable population actually feel down or getting healthcare issue, who look after you? Who will actually be there for you while you're getting burning out of looking after this special population? So that is my $1 billion question to Sarah.
Oh, actually, this is a very, we can talk about this all day long. So, in DNG, we have this very supportive people, like all my founding members, and also the volunteers are very, very close. Um, so we support each other when everyone's we face burnout several times. And no matter how passionate you are, also for me, I'm very passionate about NGO works. I work for 2 NGOs. So one is education, one is health. So it's very shifting of paradigm, but it's very very it's very very tiring sometimes, so draining, mentally, where I just juggling not just that but life in particular. I'm still growing. So it's a first, how I tackle it is because I have a very supportive friends in DNG as well. They are, for example, if one work, we just okay, I can't do this anymore. It's just I'm draining out. Then they were okay, it's okay. I'll take this job. I'll take this patient. I'll refer this to this specialist or what they will have. So I feel this is also very, very very helpful. Having helpful people around you is very good for your mental health as well. When working with vulnerable groups, it's not easy.
Yeah.
And second thing, I feel like how I look is that I will take, like, for example, I work for in like 7 days, like I'll spend my weekend like maybe 3-4 hours just like do all the like history patient or whatsoever, like communicate with my team and like handle my department and all that. And I'll just like shut everything, just like lie down and like just reflect everything of my whole life and come back again once I can. Sometimes like, I just want to like um, give appreciation to healthcare workers and also healthcare workers who work in NGO as well, because like it's really not easy. I thought it was like, just like building NGO is just like you see people help them and then like fundraise and done. It's not just that. So when I sit here and like think, like I just feel like sometimes when I eat also, like I have to like attend meeting and like, oh, this patient just came out, this case just came out, so what should we do? Sometimes like very complicated diseases, it's just like, wow, like need to do all the studies back again, like, okay, this patient, where do I refer to, and contact everyone, contact hospital, check up on the patient. Sometimes like dinner time I can't have dinner, just like talk about it. So it's very important to address not just for healthcare workers, but also NGO, healthcare workers who work in NGO as well. So I think thank you for the question, Dr. Yante. Maybe I can like ask this also, because I think it's important for me to ask to you as well, like how you handle like your mental health when it comes to like working with in healthcare system.
Thank you, Sarah, for sharing. That's actually, you're fortunate to have a very good social network and friends who understood. Yeah. Being a doctor, sometimes you can see, a lot of doctors will say, they very burnt out. Sometimes they shouted or they don't treat the patient well. I always tell my medical student, I said, those doctors who behave such, they were not like that in the beginning. Because actually everybody, I think most of everyone who wanted to become a doctor because they want to actually treat and then do good to others. But along the line, because everybody is busy, everybody is actually live in a pace that, things, saving the patient is important, getting done things important. And actually that spirit somehow dissipate and then they become a little bit not themselves, the loving doctors. Yeah. So I guess, yes, I do want to ask that, because sometimes I do wonder, we do actually feel there are times that we cannot actually give 100% because we are tired. So the support system for the doctors is also important, for the nurses, for that matter, for all the healthcare people. They became angry, probably rude, because they themselves do not have enough rest. I do notice some of the hospital or clinic kesihatan do have this small little room. If anybody who are probably tired or probably emotionally drained, they can actually just rest in that little room that is provided just to. But I'm not sure whether that is still available with all the wards has been changed into the COVID ward and stuff. But yeah, we need to actually look after each other. I always said, however altruistic a human being is and however selfless you are, yeah, we have to have a self-care and then have to look after each other. I hope that answer your question to me. Maybe not as much as I know, because I don't really work in the hospital anymore for a long time. But good
Yeah,
friends
thank you
are
so
very,
much
very important. Yeah.
for Dr. Yanti for that question. That's a very excellent question, actually. On after all, doctors are human, and we see a lot of different liners are burnt out in throughout this pandemic. Some of them have their career progression stalled because they are deployed in the COVID pandemic ward. So I'm not sure if Dr. Sarah is affected in that sense, but yeah.
But unfortunately, like no,
Okay.
which is like really
Okay.
for
Okay.
me, but also not for
Fortunately.
my friends. Some of my friends are being affected by it, so
Yeah.
it's like it's just like for me to be happy, but also I'm not happy. Like, that's like
Mhm.
that feeling. You understand? So
Yeah.
yeah.
I get what you mean. Yeah. Um, I mean, like they say, berat mata memandang, berat bahu memikul. Yeah. So anyway, we are talking about this also comes back to doctors being unappreciated, with the healthcare system underfunded, doctors not appreciated, doctors are being put on contract, and we see a lot of doctors leaving the country. Not even talking about brain drain from rural areas to a local, to big cities, but outside the country itself. I mean, just speaking from a personal experience, I know two doctors who have left for Ireland and Singapore. So, I'm not sure how true is this, how reflective is this to the population. But if more doctors leave for better opportunities, better working conditions, how do you think this will affect our healthcare system in the future, in particular the public sector?
Is that addressing to Sarah or myself?
Both of you.
Sarah, you want to go first? I might talk so much.
Okay, maybe I can talk first. All right. So when it comes to this, right, it's very, very like important for me to address just how I feel lack of doctors, also a lack of like specialists. Like I also, as Malaysian, I don't want that to happen. But also at the same time, like I look up to like my friends who live like very healthy, like they are doctors, they're medical professionals, and they also like living their life in like another country. So it's just like, wow, that's such a like a good thing. But also at the same time, I have this feeling where I just want to contribute to my country. Like I want to be a part of people who contribute to like the healthcare system, like uphold my duty as a medical professional. But also, I just feel that it's if we are like if this our healthcare system is not improved, we will see a lot of medical professional who will just migrate to another country and like work there. Like for example, I heard that Ireland is they are letting doctors from every country, and also especially Malaysia, who have like skill profession to come, especially doctors. They need that, so and we have a really good pay. I saw that, and my friends all like sending me this information. I was like, wow, okay, are you guys trying to like ask me to migrate? But also at the same time, as much as it's so nice, I need to weigh my decision, and like I just feel like, oh, my passion for like contributing to my own country is like much bigger. And also I just want to like talk about, for example, like Dr. Amalina. Like I know she's like been there for like since she was after school, but I feel like she's one of the people I was like, wow, she's working in UK, like a very like good specialist now. And how I always like go and see her live, and when she talk about how she's working here and addressing all these issues happening. So yeah, like I feel that I hope it answers your question, Ami.
Yeah, of course. Maybe Dr. Yanti. I mean, without a doubt, like living conditions are okay. Maybe not
So
without a doubt,
much.
but better abroad maybe. But there's nothing like your home country.
Yes, true. But what about you, Dr. Yanti? Do you feel? Have
Okay,
you
I will
ever
just
feel any?
okay. I have two separate answer for that. One, let's talk about the contract doctor and permanent doctor, the first question. And then we'll talk about why the doctors in Malaysia like to go and migrate or working outside. Um, from we are saying about and a contract doctor, I have a different personal opinion. I don't think that contract doctor is a bad idea. When you actually being permanent in the government services, somehow it an opportunity for you not to grow. That is my personal opinion. So for me, a contract doctor, on the basis that even though it's contract, we will actually see you how good is your service, and then we will actually continue giving you service as long as you actually do your service nicely. And then there's an opportunity of an equal opportunity for the doctor to raise up the ladder in the public services. I guess that will answer most of the reason for the young doctor to stay. Yeah. creating a permanent post, probably for me lah, this is my personal opinion, probably not a good decision, because we're talking about then the government has to make sure that you will have your pension, and then talking about how much fund to allocate, because I think we are at the end of the developing nation. There's a lot more structural thing that we want to focus. As long as the doctor is actually in a good position, able to give the service, I think they deserve to stay to give their good service. So if you put this all to permanent, then you have a lot of issue of terminating this permanent post if the doctor is not performing. So even in NHS system, they don't have permanent; it's all contract basis. Yeah, but then they have posts for all the doctors, so that is good. So I mean to say, we don't really need to create permanent, but we need to create opportunity for these doctors to practice at least for 5 years to 10 years of their, for them to actually do postgraduate, become a specialist, and things like that. So that is the answer of my opinion for the contract and the permanent. And about why the doctor like to migrate or work abroad, I have that notion before, like more than 15 years ago, when I actually sat down for FRCGP examination. It's a conjoined Malaysian to Australia, so that I can able to migrate and then work in Australia. The reason is simple. It's actually for my children. So we were looking forward that there will be better opportunity of education, and we were thinking better way, the life and everything. But if you look at the primary care doctor who actually sat down for the examination, the reason why they actually sit for this postgraduate, the MOH doctors probably want to become family medicine specialists, but many private doctors in GP, they want to actually be able to set their feet there in Australia for a better working condition. And there are also doctors who are thinking my children will have better education, especially if they have a child who needs some special education for the children. They feel that that opportunity is not available in Malaysia. So if I can work there, my child probably have learning disability or probably has some special need, that is actually being able to be provided for my children. So they decide that yeah. And the other thing is, of course, there's a nice work-life balance. They think that it is it's not so workaholic doctor as working in Malaysia, work. So they find probably a better lifestyle over there, and obviously, I think that's the why they actually go. And I think the other reason why people go is actually, we all know that with the politically unstable, you might want to say there are certain people who thinks that because I am a certain race, I don't see any future in this country, so I might want to leave. So I think that's the reason why I gather why people actually leave. There are many doctors who are actually very passionate. They want to serve their country, especially those who have taken the scholarship. And I hope they would actually try to develop. If you actually study abroad, you bring that probably system. If you feel, oh, Malaysia is so bad, so what good thing there? Try to bring back here, and then see whether we can actually working together and get our healthcare system better and develop the nation better. That's my, because I have decided, as you said just now, there's a greener pasture abroad. Then I saw myself here. I got opportunities there for my children, and we got a good life, and we can actually serve our people here better. So it depends, in what we want in life. Okay, Amir, I think that's all from me. I don't want to
Okay.
talk a bit too long.
That's a very interesting perspective, Dr. Yanti. I don't have children of my own, so I'm just thinking of myself right now. Yeah, of like better providing opportunities for children to have access to perhaps university or even the schools itself for better care, for better education lah, for that matter. Right. So I think we will move on to the Q&A. There are just a couple that I find quite interesting. Maybe Dr. Yanti and Dr. Sarah can answer. But how can medical students or university students in general help to assist in advocating for health equity in primary healthcare? So, do they come to work with Dr. Yanti or do they volunteer with doctors on the ground?
Okay, since my microphone is on, let me
Okay.
say, yeah, pre-medical student, that means they are not yet a medical student. Yeah, how to get involved in community health. Well, there's a lot of NGOs, a lot of shelter homes, or a lot of orphanage homes that would like to have volunteers. I think nowadays, you can just go to the website. Um, what voluntary work that you like to go, and then you can choose your NGOs. I think you can actually do that because, or you can actually approach people like Dr. Sarah who are working on the ground to get some idea. But for me, in my medical school, we have in year one, we actually bring NGOs and their patient to actually get involved with my medical student. And then with that introduction, they actually work with the NGO to actually do their volunteering project. I guess nowadays it's very easy. There's so many NGOs actually you can actually approach, and you have to see why do you want to do that. It's always good to see what is your passion, in which type of population that you want to work with, and then you can choose your NGOs. I think I leave it. I pass the baton to you, Dr. Sarah.
Okay, so that's simple. I just volunteer with us. Sure. No, lah. I mean, like what doctors say, it all depends on which field you're interested in. I was a medical student. I mean, I'm a medical student, so I'm still learning about everything. So if you volunteer, for example, you volunteer with us, like not only that you focus on like seeing patients, you can work with like marketing communication team where we fundraise money, we design. We have non-medical volunteers who just very interested in like medical issues, but they don't have any background in medical, but they also learn. And they also, you can also be case worker where you come with the doctors and like go to one house by house and do checkups and like write history. But like some information very personal, very, you cannot like simply just let everyone know. So with supervision of doctors, you can learn, because I learn from other doctors as well when we go on ground, like just like how to clean wound, like like very neatly than what I do. So it's a very like not just you can volunteer in this specific area, but also you can be in design team. We have specific departments for specific things. And also like how you can like contribute, you also can contribute, you can also like widen your network, you can learn. I think joining NGO, one of the great things is that I think my social skills like polish, and also how I talk to my patient, like how I talk to patients and how I talk to people, like very like improved a lot. And you can like just train yourself, like, oh, this is how this doctor like do the medical history, how they talk, like instead of, for example, you take history for such a long time, and then now you like only ask like important questions, and how you like mix two questions into one question. So it's like a very interesting for you to just be in NGO and learn, whether you're like going to medical school or before you enter medical school. I think that is such a great opportunity. So yeah.
Okay, thank you, yeah, Dr. Yanti and Dr. Sarah. So, orphanage and any other NGOs that needs help would be a good avenue for university students. So, yeah, Dr. Sarah also accepts non-medical
Yes, please.
volunteers, not interns. Yeah, okay. Can non-medical volunteers also see you clean the wounds and whatnot?
Yeah, they can come with us. It's just
Okay.
that like whenever like there's a personal information, and like we will keep that very, everything is with consent, right? So whenever the
Right.
patient is okay, comfortable, then you can come in. So we always do that, and we want also the non-medical volunteers to learn from us, and they also like not just handling patients but also external relations. Like we also have meeting with UN, like all this. So yeah, like we just give them opportunities to just learn from different backgrounds, and we also learn from like non-medical volunteers as well. Like, oh, they're good at designing, so this is how. So they are good at like communicating or like provide like networks. You know, like we gain like a lot of networks or like collaborations with other NGOs or like UNHCR and all that, just because of these people. You know, like medical, non-medical volunteers gathering efforts. So yeah.
To play an important role as well. Uh, yeah, so I have one more, maybe a few more. This is quite interesting. As a doctor, this is very personal as well for you guys. As a doctor, what is something you actively do to tackle stress personally? Dr. Sarah mentioned just now, right? She lies down. Maybe tips
Yeah.
for the upcoming students coming to the medical field.
Yes, yeah, true, true, true. I mean, so whenever like I feel stressed, you know, when everything is just too much, like I think to have passion or hobby is one of the great things. So what I do like during my free days or like where I don't have, it's not that I don't have, I won't, I think my job or like my NGO work will not finish till I die or what. But it's just like if I have free time or like just like 3 5 hours or like just go, because I'm very passionate like when it comes to climbing. So I go rock climbing, I go like I read so a lot. So if I'm really lazy, just like watch Netflix and just lie down, and then whenever like I feel okay way like my stress is just like lowering down, and just like get up and like open the laptop and do my work till I'm so tired, and just like do everything back all over again. So that's how I tackle my stress. Just like have hobby, like have friends to talk to, just call my mom, like like crying and like telling her like how suck my life is and all that. And then she'll say like everything will be okay. So I think like having a support system, having hobby, and also having like your own me time, not just, you don't have to like go out and like socialize and talk to people. You can also have me time. It's just like doing nothing also, like it's like a blissful thing for me now. I appreciate now like how much of time I should like really really use to just rest and de-stress, do meditation, yoga. I think that TNT, you do example like do yoga.
Okay, I don't do yoga. I normally talk about the stress. If I have no one to talk to, I talk to myself. I think able to talk things out actually clears the mind. So I used to actually scold my husband if he started giving me solution. I said, "Don't give me solution. I just want to vent out." You know, no, how can you vent out? Yeah, I'm giving you the solution. No, no, no. I don't want solution. I just want to be able to talk about it. That's it. So having a pair of ear to listen to your grouses, to your complaint, we call it membawang, whatever, it's actually a good thing. Very important. If we have problem or we got, just talk about it. But of course, you have to choose who you talk to. The only thing that you don't want is actually you talk to a wrong person, and your story and your problem has become the first news in the headlines. So you don't want that. But have someone, a friend, a mom, if you have, or to myself, sometimes I just look in the mirror, especially when we have done some mistake. We thought we've done some silly things. We said silly things, and then we say, "How can I say that?" And you talk to yourself. I guess talking is a good thing. If there's still something more painting up, inside you, I put my sneakers, or sometimes, I just do a bit of exercise, or do some silly dance or whatever. Just take that out of your chest. I guess exercise, ability to talk about it, and or I sleep it off. A good sleep is always a serotonin boost for me. So you will actually feel much better after a good sleep. That's how I did lah.
Yeah, true, true.
Okay, thank you. Yeah. So take note of that, students. Go for a climb. sleep, and being able to talk
Exercise.
about it is very important. Yes, exercise. Yes,
Yeah.
being able to talk about it is very important. Yeah, and I think that also applies to um, everyone, perhaps not only medical students. Non-medical students who are facing a tough time.
Also, I think crying does help.
I
Okay.
agree with you, Dr. Sarah. That's what the ladies normally have, and it is actually a blessing, to be able to cry that out.
I'll
Yes,
keep that in mind.
exactly, exactly. It's even good when like as women, like we have a like monthly thing, and then like
Okay.
so it's like your mood changes and all that. It's even like add to the severity of the crying session. So yeah, I think it does help
It
in a
hits
lot of
harder.
ways. Yeah.
Just a small notes to the rest who are actually with us here. If you really need to talk to someone and you don't think there is someone to talk to, there's a lot of channels, befrienders.
Mm.
There's a lifeline, or you can talk to your teachers, lecturers, student support. Yeah, remember, seeking help is actually a good thing. It's a sign of strength. Never think that I have stupid thing in my mind. I cannot handle this situation. I'm useless. Don't have that bad thinking in your mind. Ability to cry, ability to reach out. Those are actually important. And it's part of looking after yourself. That's my message to everyone.
Mhm, mhm. Okay. Yeah, we have a couple of questions on refugees, but I think we touched on this. The third question: what do you think refugees seek asylum in Malaysia in terms of healthcare, and how do you think this is affecting our healthcare system? Um, I think the person asking this is asking why refugees seek asylum in Malaysia, right? Do you find any truth in the question? Do they seek asylum in Malaysia in terms of healthcare, or do they just happen to seek asylum here because it's closest?
Okay, I guess I'll take this for
Yeah.
a bit. Um, so I will talk about like based on my experience and DNG's being in DNG's experience as well. Um, we have no specific reasons like why they come, and it's a very it's a very sensitive topic for us to touch when we see our um, communities, and they're also because of the language barrier we're just to know the truth. It's a bit like a long process and it's a bit hard. You have to dig, then you have to be like, if you're not close to them, you just come one time and you ask, if we have to ask that question, it'll be like a bit hard for them to just express why they come and all that. But I
Mhm,
think one of the main reasons is because of healthcare, and also because they know that Malaysia have like trying to find like job opportunities. They think that they could provide better for their families. They are fleeing from what? War,
mhm,
violence, like a lot of reasons. So we only know that, but we don't like specifically know why exactly they come. It's just that based on DNG's experience, we know that they seek of quality healthcare, and then like job opportunities and betterment of life for their families, for their kids. So that's what I can tell based on our experience and what we know from our communities who flee here from war and violence in their country.
Maybe I add a little bit on that. I think Malaysian is actually being known as a caring nation. We are stable. We don't have the natural disaster. We are not in the war. So I guess people like to come here because thinking that they will probably being looked after, and there's an opportunity of growth or providing for their family. And how do you think it is affecting our healthcare system? It does. Yeah, it does. Number one, I think they at one time, klinik kesihatan actually treat a foreign nation for 1 ringgit reference, just like the normal population of Malaysia. But I guess they realized that they have actually spent quite a lot on the foreign workers and the others. So they decided that they have to put higher fees on non-Malaysian. So it does pose a burden, but I think we cannot say just because it is a burden, we should deny them health access. So it is actually a very sensitive topic. It's actually a complex things to say. There is no hard and fast solution to this. There is no immediate solution, easy solution to actually look after this. If you ask me, yes, is it affecting? It does affecting, but we have to think about two ways. Does it affect us, or does it also affect them? You see, them who are unable to seek for the healthcare. So how do we actually settle these two issues, not just on financially how our healthcare system is actually thriving? So yes, we have to discuss a bit more and then probably do proper planning and see what are the gap or the need of medical help for our refugees.
All right, thank you, Dr. Yanti and Dr. Sarah. I mean, today I learned that there are some reasons that they come here for healthcare, because I always thought that they were fleeing a war, for example, in Myanmar, right? And sometimes the treatment that they receive here are not perhaps what they imagined. They are not exactly a welcome in terms of policy, at least. We don't have policy for them in hospitals. They can't go to government schools because they are stateless. Yeah. So okay, perhaps one last question, maybe before I return the time to you guys. What do you hope to see in our healthcare system in the near future? Perhaps maybe one of two things that you see that you hope to see in our healthcare system.
Dr. Yanti, you want to go first? I think you have much more
Okay,
experience.
all right. Before I go to that, I saw someone said, "Why is crying a sign of
Yeah,
weakness?"
I think
So I don't know.
if
I
you
said
want to touch on that.
crying and asking for help is a sign of strength, not weakness.
Exactly, exactly.
Being
Yeah.
able to address your
Yeah, like
weakness.
feelings,
Yeah.
express your emotions. I mean, that's
So I
a
just
good strength.
I just want to recorrect that question. I'm not sure. Maybe the perception is from the rest, but then what I said just now, able to ask for help, it is a strength and not weakness. Okay, back to the question about what do I see. Coming from the COVID, I remember when the COVID came in, there was this what we call that, from the Dulu Yang Maha Mulia yang di Pertuan Agong, they said that macam saying that so there's something that the emergency kind ordinance came out to say that the ordinance is to say that private and public has to work together. The health system should be able to utilize what is the facilities in the private setup. I feel that is a very good that I foresee in the future. Basically, the healthcare system should be not working in silo, meaning to say the government can actually ask for the help or the expertise what is there in the private, and the private side would actually have to have a better communication with the public, so that I think it can actually address any emergency in future if we have some more, so we'll be better prepared. Remember when the COVID actually struck us, some of the private hospital actually mobilized their ventilators, their expertise to the public health side. So those are the things that has the good thing I feel has come up from this pandemic. The working together. I wouldn't say there's no issue, but there are issue. But I guess it is all a learning curve for the private and the public, so that we actually mature together and try to work together. So I hope that would be better. Number two, I want the preventive aspect. The preventive aspect to educate. I believe a doctor is an educator. We would like to educate our children, our young mothers, how to look after themselves and their family, so that we will have a better, healthy nation. So that's what I hope to see in the future. And to you, Sarah.
So what I hope to see in the future is that, we have, like what you said, Dr. Yanti, like, I'm so proud, like we are actually working together, like, to cater this issue, this pandemic, and then so much of like initiatives being done by our government as well, to improve the public and private sector. But also what I hope in the future is, because maybe I'm like talking like more on like refugees and marginalized communities because I fight for that. But I wish to see like a solid concrete policy when it comes to like quality healthcare, not just access to healthcare, but quality healthcare for these marginalized communities. And I know it's very hard, and financially as well, it needs a very meticulous long-term planning. But at the same time, I think we can work on like somewhere, on something. So yeah, that's the first thing. Second thing, I hope to see like, just people, just as I hope that as Malaysians we accept like not just these important health issues, but also sexual health, women's health. All these need to be educated and incorporate in like syllabus and studies from such young age. I think there's no shame in like when it comes to health, whatever like field of healthcare, women's sexual, mental health. And I'm so happy that now mental health is, more exposed, people accepting it. Like sometimes I see like my friends who actually like, when it comes to mental health, they always talk about like religion and stuff. Now they're very open to it because they are exposed. I feel like, oh, I see that actually I wasn't thinking that education could actually like help, because it's like a taboo thing. Like, oh, since we were young, like whenever we were like depressed or like stressed, people will be like, oh, okay, there's something wrong because you're not like just want to say like just like close to like God or whatever. But it's not. I feel like it's not just that. It's like it digs down deeper than that. It's actually like your emotions, your feelings, your mental. So I feel like I'm very happy that people are like more exposed to mental health. But also I feel like I hope in the future we are more open to like talking about sexual health, educating our young people on like women's health, sexual health, and mental health, and also general health in particular, like obesity. I think this is one of the main problems now, is that obesity, diabetes is like a killer. Um, so I think, yeah, that's what I hope in the future, not just for general public, but also for the refugees and marginalized communities, vulnerable groups that we care for. So yeah.
Mhm. Okay, thank you so much, Dr. Sarah and Dr. Yanti. So just to sum up on that, just the cooperation between private and public hospitals, a concrete policy on the vulnerable groups, and whatnot. So I think that really would help our healthcare system. So before I return the time to you, any perhaps last words for the audience? I mean, this is optional. If you don't want to, then it's fine.
Go, Sarah. First.
One last word for audience. Okay. I just want you guys to just make this an important issue. Like, if you don't know something, I think it's important for you to just like keep learning and like ask. I feel like I if I don't know something, like I just like ask and like keep do my research, like study back. If like it's for example, whenever I see I see patient like on ground, communities, and it's even harder because of language barrier. But I also like I'm trying to learn like Urdu language, like just like to communicate with patients like a lot better. And also, I think that, for example, like this one case where we don't know, like I don't know much about this particular disease, but it's just like a learning process. So when I refer to like different people, like from different backgrounds, like specialists, like we have our consultation team where we have like doctors who don't have time to go on ground, but they can like provide their knowledge on like some cases or what. So refer to them. So I feel like the learning process, just keep learning whenever you don't know something. That's the main thing. I feel like education is whatever it is, like learning process takes time, and learning is very important. Knowledge, just gain it from everyone, like who does know it. The second thing would be like, for medical students, I feel like I think it would be a great thing if you could like volunteer, not just with doctors on the ground, but also like other NGOs that you would like to. But please come to Doctors on Ground because we need you. No lah. But yeah, I feel like this will be a great opportunity for you guys to learn more. And also, if you feel like you want to do something out of um, medical field, you can also like be with other NGOs for like design team, is like external relations, where we like attend meetings with like other NGOs. And also like for example, like we have team operations team where we handle like volunteers, so you can do a lot of various things. So yeah, I think that's the second thing that I would like to point out. And third thing, I just wish for like a better healthcare, access to healthcare for everyone. I'm very grateful as Malaysian that we have, like proper and basic like healthcare is very fundamental for us. But also, I just wish that there's a better implementation for like our communities, other vulnerable groups, not just refugees, also B40 families, M40 families, not to forget. I have friends who are like, like M40 families, but they also like, struggling with like healthcare. So I feel like I hope to see that in the future. And I think we should support that effort as well as Malaysians. So yeah. So back to you, Dr. Yanti.
Thank you, Dr. Sarah. I will echo your sentiment about education and learning, because I think learning will never stop. The moment we stop learning, we stop growing. So learning, education is actually the core of everything. And just because we become a doctor, we will not stop learning too. So it's a very evolving process. We learn from our patient, we learn from our colleague, we learn from everybody. And before I say thank you to Charisma Movement for inviting me, I would like to say also, what happened during the pandemic has affected so many people. And I guess for us, we when there's a problem, we should be part of the solution rather than just mumbling and grumbling and adding into the problem. So the only way is actually to work together, whoever we are, not just the medical can work better with the IT people in delivering the information, and we need a designers person to design this, and then we need mass communication students and we also need a political stability. And I come to that. So let's cherish that everybody have to be politically aware and probably contribute to that for a better future for tomorrow for all Malaysians. So thank you again, Amir and Charisma, for having us here today. I hope we have a nice discussion and have shared a
Yes.
little bit. Yeah.
Thank you so much,
Actually,
Ame,
all right.
Charisma.
Thank you so much, Dr. Yanti and Dr. Sarah, for taking times of your busy schedules to shed some light on community health, in particular healthcare inequality. So we learn as so much from you guys today, and yeah, thank you so much again. Nice to have you. So I will pass the floor back to Chris, who is our MC for today.
Wow, that's thank you so much to Amir and the speakers for that wonderful discussion on community health. Um, Personally, I really loved how you compared the healthcare systems in different countries and how we can emulate others in improving our healthcare system moving forward. um, just a really great discussion, and I would like to thank all of you once again for giving your insights and giving your input into this wonderful discussion. So yeah, moving on to the next segment of our event for today, we'll begin our first round of lucky draws right now. So okay, let me look at the generator. The names are in, they are generating, and oh my, okay, we have ourselves our first two lucky winners for this event. Oh my god. Okay.
Is it the panelists? No. Is it one of Sarah or Dr. Yanti?
I mean,
No.
I can't disclose that just yet. If you
Okay.
guys want to find out if you have won, do follow us on our Instagram at Charisma Movement, and keep an eye out for our stories. Keep yourself posted. Yeah. So the two people for our first lucky draw will be going home with 50 ringgit Shopee vouchers. Wow. Okay. So yeah. In the meantime, we're going to take a 1 hour break. So please feel free to, walk around and freshen up. We'll reconvene at 5 p.m. for our discussion on mental health. See you guys then.
All right. Thank you.